for the treating obstetrician as well as the patient. Over the years, there have been some innovative changes in management of PPH. We have better uterotonics. What I feel is now with the use of carbetocin, the incidence of atonic PPH has drastically decreased. We are getting very good results with that. And we also have, like before opting for obstetric hysterectomies, we have several maneuvers, that is, be it the bimanual compression or the uterine balloon tamponade, or before we can go for stepwise devascularization or the compression sutures. And if everything fails, of course, we do have obstetric hysterectomy. Internal iliac, we cannot forget the role of internal iliac artery ligation. We as obstetricians should be aware of all these different procedures, and this is the very aim of this webinar, which has been designed by Dr. Sadhana Gupta after lots of hard work to gather a team of experts. She stands here with the belief knowledge is something to be shared. Before starting a scientific session, let us join our hands and take blessings of Ma Saraswati, the goddess of knowledge, and also join for the lighting of the lamp. Tulika? Goddess Saraswati, ignite the darkness of ignorance with the light.
Arogyam dhala sampadah Shatrubuddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham Gurutvam Kalyanam Arogyam dhala sampadah Shubham Gurutvam Kalyanam Arogyam.
So it is indeed a very divine pleasure to listen to this music. Now it is my pride and pleasure to invite the key organizer of this webinar, a hardcore clinician, a humble lady with leadership qualities, Dr. Sadhana Gupta. Madam is co-chair Suffolk NCD committee. She is FOXY representative to Suffolk 2018-21 and vice president FOXY 2016.
It's okay.
Ma'am, she's ICOG Governing Council member, corresponding national editor and peer reviewer of the Journal of Obs and Gynae and Journal Support. Ma'am is past chairperson FOXY Safe Motherhood Committee. She is 4 times best AICOG research paper, sole author of books on several books, cesarean delivery, vaginal delivery, and many more, recipient of several awards, organized several CMEs and conferences, and above all, ma'am is the most deserving presidential candidate for the year 2023. A very warm welcome to you, ma'am. Kindly give your words of blessings and also invite and introduce our chief guest of the day, Dr. Pelli.
Thank you, Babita. First of all, as a key organizer, I owe a big thanks and welcome to all office bearers as well as members of Coimbatore, Trivandrum, Vellore and Namakkal Society. President Dr. Manomani, Dr. Murugulakshmi from Coimbatore, Dr. Radma Devi and Dr. LMLU from Trivandrum, Dr. Manisha Madhai and Dr. Swati from Vellore and Dr. M. Chandra Ponusami and Dr. K. M. Lata from Namakkal. Because it is your effort and cooperation that makes the thing happen. And on this outset, it is a pride and pleasure to be with Dr. V.P. Pelli and Dr. Sheila Mane as a chief guest and guest of honor who have done exemplary work on obstetrical hemorrhage around the country and across the country. They have been the figure who have inspired our generations to work in FOXY and other professional associations for preventing the preventable maternal death. Dr. V.P. Pelli is our chief guest and we are highly motivated to have him as a chief guest in this E-Classic for Clinician Skill and Drill PPH workshop. Dr. Pelli is a known figure like at international level. To formally introduce, he is senior consultant and head of the Department of Obs Gynae Department in the Rajgiri Hospital. His special interest is high-risk obstetrics, urogynecology, endoscopy, and infertility. He has been past president of Kerala Federation of Obs-Gynecology, and only last week we were at the KFOG conference, and we looked his exemplary leadership in the conference and his following. He has been state coordinator for confidential review of maternal death for the Kerala, and this is again a landmark achievement for a great collaboration and organizing capacity that he could have that quality confidential review of maternal death for state of Kerala, which even Western world could not have. And I appeal everybody to go through his reviews and his recommendation to Government of India and the practitioner, and these are the lessons in themselves. He has been state coordinator for emergency obstetrical care and life support, IMOCALS Kerala, and state coordinator quality standard in obstetric care. And when a world is looking for quality, universal, accessible, affordable obstetrical care, Dr. V.P. Pelly, like Pearson, is going to lead and guide the way. So a great welcome, Dr. V.P. Pelly, and kindly bless this event with your pulse of wisdom.
Thank you. Thank you, Sadhana. Am I to start now, or do you want to introduce Sheila also before that?
Please.
Okay. Okay. Thank you very much. Thank you, Sadhana. Thank you, Dr. Babita, Sheila, and all my friends there in Southern societies of Vellore, Coimbatore, Namakkal, and Tiruvannamalai. It's a great honor to be asked to be a part of this series organized by Sadhana. Best of luck for you, Sadhana. Our best wishes with you for your presidential elections. Now, the topic you have selected to spread across is of vital importance. And it was already mentioned by Babita and yourself, how important it is to tackle this issue of hemorrhage associated with delivery, because that unfortunately remains even now the leading cause of maternal death all over the world, except the very developed countries. Developing and very poorly developed areas of the world are still suffering from this problem of hemorrhage as the leading cause. We talk about PPH, postpartum hemorrhage, but that encompasses not just atonic PPH alone. As the facilities improve, what we see is more and more of traumatic as well. And the abruption still continues. And if you put it under the basket of hemorrhage, hemorrhage associated with abortions, hemorrhage associated with ectopic pregnancies, and the hemorrhage as the final common pathway for death in cases of amniotic fluid embolism, all these have to be considered together when you consider hemorrhage as a cause of death. The good news is, as was mentioned by my earlier colleagues, Babita as well as Sadhana, there have been remarkable progress in our approach, our ability to tackle that problem and save the woman. What I would say is a paradigm shift has taken place already. And those of us who do not take it up will be losing their patients, their mothers. And I think it is unjustified, even now, not to take up these very low cost, practical steps that we have come out with. I am referring to the suction cannula as a device to stop the bleeding, the transvaginal uterine clamp as a device to stop the bleeding from the lower segment, the aorta clamp as a device to control the bleeding when we are tackling placenta accreta spectrum. With these three devices, there will be a radical change in the outcome of PPH. But in addition, what all of us practitioners have to understand is, as Sheila also will probably promote, there has been a paradigm shift. No more we should talk about condom tamponade as the first line. No more should we talk about stepwise devascularization and taking to obstetric hysterectomy. Because as I have been telling from many platforms, in the last nearly 6 years, after vaginal delivery, we did not have to take one patient to the theater for the surgical procedures. When we started to use the suction cannula as well as the transvaginal uterine clamp, that is the revolutionary change that has happened. During cesarean, you may have to approach more easily straight away to procedures like uterine ligation or brace stitches or ovarian branch ligation or internal iliac ligation. And as was mentioned by Babita, internal iliac ligation is an important step all of us have to master, but no more for atonic PPH. For traumatic PPH, we will need it. So we should maintain our surgical skills. In addition to that, what I have to say is, if it's a patient profusely bleeding during a cesarean or ruptured uterus or whatever it is, the first step that we can do is put the clamp, the aorta clamp. That gives you time to work. That gives time for the anesthetist, because otherwise whatever he is giving at the head end, fluid or blood, is being lost through the open vessels. So stop that bleeding by putting an aorta clamp. So that is why I'm saying a paradigm shift in our approach to PPH is required. Not PPH alone, hemorrhage as a cause of maternal death. And those who do not embrace it are actually doing an injustice. I think these days there is no more justification to ignore the cannula and the clamp. More than anything, the most important thing is they are so much affordable. We are trying to develop a disposable plastic cannula, which can be just available everywhere. You all have your suction device in the theater, in your labor room. Suction for creating vacuum extraction. Suction in the theater. You have the Yankor or Romson's suction tube, 2 meters long. At the end of that, they provide you a suction tip also. If only we have multiple holes at the end of that, that becomes a suction device. That is what we are trying to develop. Hopefully soon we will do that and develop suction device as a disposable method rather than the steel cannula which has been washed and then re-sterilized and all that. So my plea to all my colleagues over there is, please watch what is happening. And these devices are promoted with no personal profit in mind. It is just to save mothers. Embrace it. Take it up, because they are to be used by the person on the spot. You cannot wait for your senior to come and help you. So from that angle, what we are promoting is suction cannula and the clamp after vaginal delivery should be used, if necessary, by a nurse who is conducting the delivery. That's the other change. Otherwise, by the time the consultant comes, it is too late. So the other tip that we are recommending is, we talk about measuring blood, how much it is, 1000 ml, then it is PPH and all that. No. The moment you see bleeding is excessive, start the treatment. And Babita already mentioned to us about the improvement that has happened with carbetocin. Unfortunately, even now, all the state governments have not come forward and procured carbetocin. It still remains expensive, costing nearly 400 rupees per vial. That's, I would say, not paranormal, because it is a useful drug. We should make it available, especially when the company has promised to supply it at the cost of an ampule of oxytocin to at least the government centers. So the government centers in the country should procure it and distribute, but that is not happening. We don't want to dissect and find out why it is not happening, because that may not be very palatable. But my plea is, friends, paradigm shift is required in our approach to PPH. Deaths due to hemorrhage should be brought down. And we owe this responsibility, because this generation of obstetricians cannot say, oh, I did not know. Because all over, in every meeting, these things are being projected. You cannot say that you could not afford it, because a clamp that you buy for nearly 20,000 rupees, the whole set, will last for you and your next generation. So you cannot say it is not affordable. This knowledge is there. Embrace it. save our mothers. That's all my plea. But thank you very much, Sadhana, Babita, and all our colleagues there for spreading this message and taking it to all the centers so that more and more people will take it up. Thank you very much.
Thank you, Dr. Pelli. And rightly you said, and like we just last week, and I have been the strong propagator of Samartharam and Panicker Cannula all over the country, and he has come to all Saving Mothers Conference and many programs. So I've got wonderful, we have got wherever, very, very small village and town, and they say, the people say it is not Samartha or Panicker says, the people say that it is almost 100% effective. And what you said, that we don't have to need to go to the operation theater. So that is the thing. It is a paradigm shift, and the availability of carbetocin, of course, 400 rupees for a life of women or for the quality obstetrical care for women. So we have to think what we mean by women empowerment. If our women really need such a, not a that costly, only 400 rupees, right? So it is mindset. I think what sir has said about it, it is paradigm shift in our mind as well as in the heart, that what we have to change our mindset for the management of postpartum hemorrhage for a wider range and the wider spectrum. Thank you, Dr. Pelli. Listening to you is always a being with a guru, what we can say, and it gives us a lot of motivation and inspiration to work ahead. And thank you very much, sir, for your precious time. And Babita, can I have Dr. Sheila Mane?
Yes, yes.
So Dr. Sheila Mane, it is a really a very, very warm moment for me when like I introduced Dr. Sheila Mane, which once we have coined for ourselves, that is the twin face of safe motherhood. And sometimes I think we have started resembling also. So she is currently DNB faculty and KCG Hospital, Bengaluru, ICOG Governing Council member, and she is Vice Chairperson elect ICOG. Vice President Foxy T014 2014 and Chairperson Safe Motherhood Committee with award recipient of Best Committee Chair Activity.
Thank you.
So she is known all over as a PPH lady, and she has innovated many ways of teaching, and it is a great pleasure to have Dr. Sheila Mane with us. And please like share your words of wisdom to everyone.
Good evening, Sadhana ji. And it's really a proud privilege to be here. And I thank everybody. And it's a nice initiative, the 4 societies who have joined. I would like to say namaste to all the organizing as president secretaries, as well as the delegates of Vellore, Coimbatore, Namakkal, and Tiruvannamalai Society. It's very nice to see that so
good
many
evening. Sheila madam, good evening.
Good evening.
From Namakkal, Chandra from Namakkal.
Yes, yes, we met at Pondicherry, I remember.
Yeah,
I can still recognize you,
yes.
both of you. Yes. Yeah. Thank you. So after listening to sir, all of us, we know, and I think in my journey, since I have started working towards this cause, I think I have learned a lot from Dr. Pelli sir, and we know we still keep looking at you, sir, to learn so many things. But as you said that there is a paradigm shift, yes, that is there. Carbetocin, we hope that the company is willing to give only for the rupees 89. So I think every state will have to tell the state government the importance of it. And I think I'm planning to do a study now, and which is in one of the district hospital of Karnataka only, with carbetocin, and then I think I'll be able to convince the government that how useful it is. That is what. Now, regarding all the procedures, whatever we have, I think prediction, prevention, as well as the management, all of us are aware, but still we are losing. Yes, there can't be a case where or obstetrics without 0 PPH, but we should have 0 deaths due to postpartum hemorrhage. And that should be our motto. And for that, I think all of us have to be alert, because even the WHO has come up and saying that always the resuscitation starts late. So that is why the WHO has a now E-motive approach. And in that E-motive, they say that M is for massage, O is for oxytocin, T is for tranexamic acid, and then IV is for IV fluids, and then A is again enhancement, or you will have to explore whether there is a other cause. Now, as Dr. Paili sir mentioned about traumatic postpartum hemorrhage, I must say, yes, it is a problem today. And I would like to just share some of my experiences, what I feel. I think everyone has to learn management of labor properly. The management of labor, even though we know that there are risk factors, antenatal risk factors we look into, but even the intranatal risk factors also we have to look, and after the delivery. But sometimes, it is becoming iatrogenic. So all the youngsters have to know the risk factors beforehand. That could be the prediction and the management of labor properly to avoid all these unnecessary complications which can happen during labor. Because over a period of time, when I have the juniors, I have the postgraduates, I am observing them. And I wanted to give this message that all of us have to really give a thought to the management of labor. Now, coming to, I think all stalwarts are here. Dr. Nalini is here, Dr. Shashi Kabra, Dr. Manor Mani, Dr. Josna will be joining. So, nice gathering today, where everyone will be almost going to cover each and every aspect of postpartum hemorrhage. So let us look forward and listen to all the seniors and take their message. Now the initiative of skill and drill, and thanks to, I think, COVID time, that we have learned to do even this online and spreading the message everywhere. And we did it, and we continue to do that. So I think, again, when we come to this, the skill and the drills are very important, because I always remember the thing that you tell me, I remember. You tell me, I remember. That is Benjamin Franklin's word. You tell me, I remember. You teach me, I learn. Okay. But if you involve me, okay, I remember. I mean, that is the thing, that if you involve everybody, and that is the importance of doing this skill training as well as the drills, where it will get imprinted in their brain and mind, and they will not forget. So I think still today, there is a need for skill and drills, and to see to it that, as I said, there should be zero death due to postpartum hemorrhage. We have to really look at that, and we all have to march towards that. Thank you very much once again for inviting me and giving me this opportunity. Good luck, Dr. Sadhna. And we wish to see you as a president, and we wishing you a good luck on this occasion from me. Thank you.
Thank you, Dr. Sheila, for your precious words and your precious wishes as well. And we look forward to work together for collaboration and reaching every woman irrespective of place and the status. So we have worked a lot of things to do together as ICOG, as FOXY, and at many professional body associations. So thank you, Dr. Sheila Mani. It is great pleasure to have you. So, Babita, you can go ahead with the program. Yes.
So time is really important. Without wasting any time, let's straight away move towards our scientific session. Our first speaker is none other than our Sadhna Madam, who will be covering the topic prevention, diagnosis, and management of PPH. And for this session, I would like to invite our esteemed chairpersons, Dr. Manomani. She is Best Outgoing Student 1990 MMC. She is COGS Managing Committee member 2017 to 19 and Chief District Obstetrician, District BEMONC trainer.
Thank you.
And she has
Thank you
served
for
Tamil Nadu government for 26 years.
I think
And our second chairperson is Dr. Radha Madhvi S. She is founder, president of COGS, Professor, Department of Obs and Gynae, Christian Medical College and Hospital, Vellore. She has several publications in national and international journals and has a special area of interest being high-risk pregnancy and fetal medicine. A very warm welcome to our chairpersons. Now I hand over the session to our chairpersons to introduce the speaker and conduct the session.
thank you.
Thank you for inviting me as the chairperson. Good evening to one and all present here. I thank Dr. Sadhana, Dr. Babita, and Dr. Aishi for involving me in this e-drill, e-clin classics for clinician and PPH drill. So it is my proud privilege to introduce Dr. Sadhana Gupta. As all of you have known, she is co-chair SAFOG NCD committee and has been known to everyone, and she is the Foxy presidential candidate for this year 2023. And we welcome you, ma'am, to tell us on prevention, diagnosis, and management of PPH, what every obstetrician should know. So the bread and butter of managing PPH. So following each delivery, how we have to prevent PPH. So welcome you to this, and thank you for the opportunity.
Thank you, Dr. Manomani and Dr. Swati, for being chair for this important session. And the already stage has been set by Dr. BP Pellis and Dr. Sheila Mani's address. So I will go through a little bit 360-degree view of PPH when we get the call of postpartum hemorrhage, how the things should go. So this is important because today everybody knows. Sometimes, yes, few people really are not have that capacity, but many people know many things. But in the chaos of all postpartum hemorrhage, and everything gets lost sometime, and we lose the time, and sometimes we lose the chances to reduce criticality and the mortality. So I will cover the basic things, and I owe a big gratitude. Today I also thank a big gratitude to Coimbatore, Trivandrum, Vellore, and Namakkal Society for being together. And I have been very fortunate that I have received cooperation, collaboration, advices, guidance for so many legends, so many members, so many office bearers, that we could do a little bit to improve women health in our country. I bring greetings from the land of Buddha and Krishna, who says we can never obtain peace in the outer world until we make peace with ourselves. And PPH really tests that how peaceful, composed, and cool you are when you are dealing with a situation of the postpartum hemorrhage. So this is all. We always reiterate at the background that PPH is still contributing 25 to 35% of all maternal death, and around 60% of all maternal death in developing and poor countries, and Africa and Asia constitute major proportion of maternal death. What is the clinician perspective? Because statistics sometimes look too distant, and actually we are not sensitive to that tragedy what we are facing. But the clinician perspective, we are really sensitive to it. So it is going to happen in 2 to 10%. If the human race is going to deliver, we are going to encounter postpartum hemorrhage. And out of this, 1 out of 1,000 can be very massive and life-threatening. We need aggressive management, very time-bound management. And if the woman survive even PPH, she can have a long time scar on the health, like severe anemia, any surgical procedure, blood transfusion related morbidity. So it is a lifetime scar for obstetrician and their team also. So it is always, we really don't want to remember. It is so much of sadness that when we lose suddenly patient in the short span of 1 to 1.5 years. So this is important, that it is a thing which has to be dealt with. And when you face postpartum hemorrhage, especially moderate to severe postpartum hemorrhage, it actually tests everything. What is our health system? What are our society values? How much women is empowered? How we have given the capacity building to our paramedicals, because it is a test for your leadership, your quality, your judgments. So the basic thing remain the thing that don't issue trauma thrombin, that we are going to deal in next 15 minutes, but we can lose the patient very rapidly, and we have to deal with the changing obstetrical morbidity. That is very important. What Dr. Pelli was pointing out, that we are struggling with all the age-old problem like anemia, 3 delays, but we have all the new problems not in a very reduced number. It is quite around us, which is pregnancy with myoma, IVF pregnancy, multi-fetal pregnancy, pregnancy with high risk medical disorder on the different drug, and that makes our things more complicated, and we have to be upgraded in our knowledge and skill. So why this e-skill and drill workshop is we are doing in physical as well as in the virtually? We want to have few things out of it. That is, we prevent the life-threatening PPH. We want to prevent the severity of PPH. We want to say a very clear decision-making ways when the things are going haywire. Managing PPS with success will enhance our confidence, but if we lose the patient, this is really a lifetime scam. So what is the implication if we don't manage it right from antenatal care to the postpartum care? Because the implications are too bad. It has potential effect on the well-being of mother, family, and obstetrician, and also potential medical legal issue. So this is SIT, please mute everybody. Potential. So this is very important because younger generation is going away from the obstetrical practice because of this unpredictability of obstetrics, and that should not be the way, especially for a country like India. So we have to deal with all three delays, and we have to be very, very alert and ready at our health facilities. So one thing about prevention, we will start right from the prevention. Can we prevent it? And it is $1 million question. So how can we prevent it? It start not in labor room, it start right in our antenatal period. So whenever you have any of these situations which can cause the sensitivity, the vulnerability of women to have postpartum hemorrhage, please write it down. So it is very important. Multiple pregnancy, preeclampsia, grand multiparity, treatment with anticoagulant, which is very, very common nowadays. We have to write it down and flash it on the antenatal card and counsel the family that she is having high risk for postpartum hemorrhage. She might be needing the blood component, and sensitize all labor room staff that they read these flash points and the alarm and communicate with the senior obstetrician that this thing is there. So from active management of third stage of labor, we have come right 1988 to 2012. So these are the 4 arms, but the oxytocin, the oxytocin injection within 1 minute of the delivery of the baby remains the most important arm of the active management of third stage of labor. So all the advantage, reduce risk of PPS, severe PPS, blood transfusion, everything it is there. And it is a vaccine which has to be given to every woman whosoever is delivering. So we can use 10 unit intramuscular or in the fluid. But as Dr. Pelly says, and I have been using totally 100% universally carbetocin to all patients with vaginal delivery and cesarean delivery. And it is a very, very good effective alternative, and it has certain advantage over oxytocin. Misoprostol we are using as a prophylactic, but I want to give this message that it is a second choice as a active management of third stage of labor when you don't have injection facility or some issue with the approachability, and it can like it is a less costly, there is no storage or the difficulty of administration, so we are using it. So all professional bodies advocate for the active management of third stage of labor, and carbetocin is a paradigm shift, which is a long-acting oxytocin, very, very strong affinity to oxytocin receptor, and it is important that we utilize the benefit of this drug to our women. Champion trial, after which it came into the market, and India was an important contributor to this trial. And the key is the give 100 microgram in 1 ml in the 1 minute to be delivered after delivery of infant, and it can be given after cesarean delivery and the vaginal delivery as well, and a very, very strong affinity to oxytocin receptor. What is so very good about it that it is room stable. So the issue of oxytocin, because as a chair Safe Motherhood Committee and a Path Oxytocin initiative, we have worked a lot about that the oxytocin to be kept into the refrigerator right from the production to pharmacy to the retail center. But we have got a very high temperature in most of our part of the country. So carbetocin, room stable carbetocin, eliminates the need for the refrigeration, that is cool chain, and it also eliminates the need for infusion after the initial dose. So whenever there is a severe anemia or heart disease or preeclampsia, and we don't want to give the oxytocin for a prolonged period, then this carbetocin can be a very useful alternative. So the things we know the drug, that these are the drugs which can be used as active management of third stage of labor. But this is also very important that all these drugs should be available right at the bedside of the patient. So this is also very important. For this, the all regular PPH box, refrigerator at the nearby labor room, so that should be available. So the most important arm of active management of third stage of labor is the use of uterotonic, and the other are the late cord clamping, the controlled contraction in setting only when there is a experienced skilled birth attendant. So this is very important, that controlled contraction, WHO has put a bar on it, because if it is not done properly, it can cause itself the postpartum hemorrhage, mild degree of inversion, and the relaxation of the uterus. So this is very important, that controlled contraction is only applicable when your staff or the doctor or the nurses is experienced in doing it. So coming with this risk assessment and the active management of third stage of labor, we are coming to management of postpartum hemorrhage, and the key word is the more you sweat in peace, the less you bleed in war. So it is our day-to-day management issue in the labor room, which really works when we are in the trouble. We have to face the postpartum hemorrhage in an unpredictable manner, and we have to be ready with our all fire drills. So why do mothers die? Because we don't diagnose early, we don't correct hypovolemia that aggressively, and the treatment is the control of the bleeding. So coming to resuscitation and medical management, this is a vast topic, but I will give few key messages that in the first hour after beginning of PPS, that is the time when we can save the woman. And for this, for every woman, there must be policy that patient to be kept for that 1 or 2 hours after delivery, not to be shifted into the postnatal ward. And in that golden hour, we have to look for bleeding, tone and height of uterus, vitals, level of alertness, and the oxygen saturation. So this is very, very important. We can have primary and secondary postpartum hemorrhage. All august audience know any blood loss which makes the woman hemodynamically unstable is also termed as PPH. It may be 200 or 300 ml. So when you are given the call, this patient is bleeding, what you are supposed to do? First of all, make quick 360-degree view of whole situation. While we are doing resuscitation and initial management, cause analysis at the back of our mind is very important, because we have to treat the cause as soon as possible. So tone, tissue, trauma, thrombin, we all know. Just in that 360-degree view, you have to see what was the cause. What she was the high risk for atonic, she was chorioamnitis, she has been given uterine relaxant, or she is having fibroid in her previous ultrasound, or something related to over-distended uterus. So it is all about 360-degree view, that this patient is more prone to have the trauma or the retained placental tissue. And what happened, what Dr. Sheila Mane was talking about, the labor room protocol. So what happened into the labor, that will give you idea that what type of PPH today in this case you are going to handle. So quick cause analysis is important. So tone, we will cover a lot, trauma, retained product, and coagulopathy is the thing where still we have the gap. So this is important, and we can have combination of the causes, because patient doesn't come into according to our tables or our charts. It comes as a whole. So the patient have PPROM, she has an infective etiology, she was given uterine relaxant, she is having atony, and the chances for difficult delivery of the placenta. So all causes, tone, trauma, infection, coagulopathy, everything can come together also. So we have to be very, very careful about it. So the second thing is, Why we miss the early diagnosis? Because the patient is having high cardiac output and the high blood volume due to pregnancy. So patient can lose quite a good number of amount of blood volume without any change into the vitals. So this is very important, that normotensive women can be hypertensive initially, and hypertensive women can be normotensive despite remarkable hypovolemia, and you have to be very, very careful about it. So estimation of blood loss, I think all the people are using it, that how we can improve our visible estimation of blood loss. Dr. Nalini is going to tell about a good, very, very doable measurement of blood loss also. So just my message is that give clear instruction to labor room staff. That is, if you are having 5 soaked normal size pad, 1 soaked big sanitary napkin, she is continuously bleeding, you have quantitative blood loss that is going across 400 to 500, and the altered woman condition. That is very important. If the patient is having confused, she is not feeling any pain, this is very, very important sign that patient is losing blood either outside or inside. So call for help. It is important. Choose your friend in need ahead. Asking help is not a loss of face. And whom to call? It should not be to the walls. We should be very, very methodical, that it is anesthetist, nurse, obstetrician, colleague, good, smart ward boys and the guys and the theater staff and the blood bank person. These are the persons who to be called about it. So a quick assessment, airway, breathing, circulation, and the cause analysis and the severity of hemorrhage. So it is about pulse, BP, tissue perfusion indicator, urinary output, and capillary refill, which we can make very, very quick assessment how much the woman has left blood. And the shock index, when we have the cardiac monitor in our labor room, we can very, very easy, very, very doable thing, that it gives you instant idea that how much patient has bled. And if it is more than 0.9, then it is the thing that we should be very, very careful, and we should be that aggressive according to the amount of blood loss and according to the shock index. A golden classic teaching always remains with us. Pulse, the rule of 30, high pulse rate, the pulse rate high, systolic blood pressure fall, respiratory rate rise, and the urinary output drop. And this always remains with us. So a good visible estimation, good quantitative, we can use anything which can quantitatively also measure the blood loss, and a 360-degree view. And now this is the time to have our drugs, oxygen cylinder, emergency trays, chart, and all the contact number. So the basic EMOC we have to give, that the crystalloid, we will just go. So these are the all things which we have to do. This, what, when we are resuscitating the patient with the postpartum hemorrhage, and if there is a more like a moderate to severe hemorrhage, then the resuscitation protocol should be very, very aggressive. So it is very, very important. So airway, breathing, circulation. When we are having moderate to severe PPH, it is always a good idea to give oxygen irrespective of oxygen saturation. IV access is very important. So always keep either no pink cannula in the labor room, it is green or the gray cannula. Keep the woman flat and the warm. And we have to, our lifesaver is the crystalloid. Catheterization of the bladder is very, very important. And of course, when the patient is loose, like having a very unstable vital, then the aortic compression is with us. So resuscitate, investigate, monitor, communicate, and record keeping. So in all the issues, we cannot forget every moment that we have to communicate to the patients and the attendant that what is happening, because otherwise if they are not in loop, then it really creates problem in the future. When you are inserting intracath, you have to send all the investigation, liver function, renal function, coagulopathy, blood group cross matching in the plain EDTA cited by. An important thing is that these vials should be available in our PPH box along with the blood bank forms as well as the investigation form, so that we don't use waste our time in searching the blood transfusion form or the lab investigation form. So it is a WHO postpartum bundle care, and as a Foxy presidential candidate, it is one of my really statement to have to improvise the maternal health by the approach of all bundles for the prematurity, for the sepsis, for the postpartum hemorrhage, so that we bridge the gaps into the healthcare. So bundle approach we have to apply, and that talks for the uterotonic drug, crystalloid, tranexamic acid, and the uterine massage. So again, to reiterate, airway, oxygen, 2 IV cannula, and a fast crystalloid. So Ringer lactate and normal saline. And if you think it is 1 liter blood loss, then it is, you have to infuse around 3 liters of the crystalloid to the woman. So this is very, very important, because the colloid is not the first drug of choice. I think everybody knows it, but we have to be careful, because colloid can cause pulmonary edema because they are retained into the intravascular space. So the second is ask right question. So if placenta not delivered, mobilize team for MRP. If placenta not complete, mobilize for exploration. If there is a suspicion of accreta spectrum, no attempt should be made to remove the placenta, because it may lead to catastrophic bleeding. So you have to be very careful. What happened if the patient was bleeding before delivery, or if the patient was bleeding after delivery. So catheterization, uterine massage, this is an art which all obstetricians have to retain, how to make gently rubbing and the rotate. You have to remove the blood clot, because the retention of blood clot itself can cause the atony. Again, the medical management after this initial resuscitation, these are all drugs which are available to us. Important thing is that we optimize their dosage and their, exclude all contraindication and optimize their usage according to 1 by 1, because we can use the 4 ampule of methyl ergometrin, 8 doses of the prostaglandin F2 alpha. So this is important that we have all these drugs and we use this drug in the rapid succession, because the patient who have been augmented by induction for the oxytocin, they may not respond to oxytocin. Then we have to go for the PGF2 alpha or the misoprostol or the methyl ergometrin. So important thing is that optimize the dosage of the drugs, optimize the usage of drug by excluding indication and contraindication. And like in the lower segment bleeding, then ergometrin is going to work better than the oxytocin. So this is important. A PGF2 alpha, you can give 8 doses, but after 3 doses, if the uterus is not contracting, then we should search for the other causes. Tranexamic acid, then again a woman trial which has been done in my Foxy journey. So the tranexamic acid is a drug which has been recommended by WHO. It has to be repeated. It has to be given at the diagnosis of postpartum hemorrhage and repeated after 30 minutes if bleeding continues. But if you use it very late, then it is not going to help. It may be going to harmful. This is very important slide which I wish to communicate, that there has been report for maternal death because tranexamic acid has been inadvertently used for the regional anesthesia. And it is the paper from anesthetist, and in the medical council, there has been few mortality cases which is being done with this. So I will say a very small thing, that keep a magnifying glass in your OT so that you don't have these human errors for missing the injection and misreading the injection. Blood transfusion, it is coming whenever you have the moderate to severe postpartum hemorrhage, less hemoglobin than 7 grams. And again, the availability of HemoQ. Right at that point of care, we must have the HemoQ that gives you fair idea. If it is 10 or 11, you have breathing space. Even you have 9, but if it is 6 or 5, you have to be very aggressive for blood transfusion as well as treating the cause. So this is very important. Whenever there is any predisposing condition which can cause disseminated intravascular coagulation, please look for that, because that is the basic thing for the diagnosis of DIC. So all IUFD, severe PPH, abruptio, HELLP syndrome, they can cause coagulopathy and they need the a tailorized blood component therapy. We talk about so many elastography and a costly test, but the coagulation profile to be sent on the lab, but the bedside test also give you at the point of care idea. And Dr. Nalini Mishra has written a very good paper which has been published by the FIGO group, that how these bedside tests can give you a fair idea that it so well correlate with the fibrinogen level and need for the blood component therapy, whether we should use this component or not component. So this is very important. Massive transfusion protocol, just a one word about it, because I see a lot of confusion among themselves. Like from the very beginning, we don't need that 1:1:1. After 3 or 4 units of PRBC, after that massive transfusion protocol start, and then it is 1:1:1. So what we want to achieve with the blood transfusion, we want to achieve all these parameters: hemoglobin 8 gram, platelet count more than 75,000, and prothrombin less than 1.5 mean control. So be ready with your PPH tray. With the Manyata, we are really propagating, and so our trainer, Dr. Babita, they are the like Manyata trainers, and I've been Manyata champion since 2013, and we really rigorously teach and advocate that the all trays should be available. Always record communication, because it is always a potential medical legal issue. So we have to communicate, we have to allocate somebody who write down all the events. So it is Manyata, which we say that we join Manyata. Treatment of the cause is very, very important. If it is inversion laceration, that need to be treated. Conservative surgical management, so it is bimanual compression. We all know, just we have to teach this art to every nurse and every junior resident. This is what Dr. Pelli was talking about. That is the Samartharam and Panikkar's innovation. It is a simple, actually, science, and it gives such a wonderful result. It is all about contraction and retraction of the uterus. So these are the cannulas, and these are the very, very simple, like a very, very low cost procedure, and it should be available in our labor room so that we can have it a pick of time. And what Dr. Pelli was saying, that we are having now, like ordering some like plastic suction, like a Carmen cannula, which we use in MTP, the same way we can have, so that we can not worry about the sterilization and other procedure. Patient when to be shifted to OT or not, what we are going to do. So don't waste the time. Sometimes too much knowledge also cripples us. We should be very, very clear about it, what we are going to do, how when to explore, how to explore for all these traumatic procedure, cervical tear or the hematoma. This is Dr. Pelli's transvaginal uterine artery clamp. And again, I will say that this suction cannula and the transvaginal uterine artery clamp should be available in every labor room. So this is, you can apply after vaginal delivery and you can clamp the uterine artery. So these are the papers, what Dr. Pelli was saying, that it is a very, very important like armamentarium to prevent the preventable mortality with a very good result. We are going to discuss the tympanote like by Dr. Nalini Mishra, who has innovated Chhattisgarh balloon, and she will be the detailing the thing how to make it right at the point of care. Retained placenta, whenever there, you have to follow the protocol, and the real difficult part about MRP is the decision to undertake it. So, and the of course art of MRP, that is gentle, peering the like a page of book and ensuring that the uterus is contracted. So coagulopathy, I will again say that we are really encountering thrombocytopenia, primary, secondary, drug-induced immune thrombocytopenia. So we have to be careful about it. And when it is time to open up in PPH, this is important, that you must be very vigilant that this is surgical cause and I have to open it. So good decision. And when the patient is very low, life-saving is the aortic compression, bimanual compression, NASG, and do the things whatever it is needed. So this is important. We have to develop a skill and the practice skill. So to conclude, we have to save life. We have to prevent the preventable maternal death. This is a drastic situation which need aggressive measure. We have to set protocol, good decision, readiness of our team, and prepare team of friends. If hysterectomy needed in rapidly deteriorated situation, do it, and have a sharp eye on potential medical legal issue and keep good communication. So this is the final saying: if you can fill the unforgiving minute with 60 seconds worth of distance, run, run, run. And it is all about PPH. And with this, I seek your full-hearted vote and support for my Foxy presidential candidature. I have served Foxy selflessly, and I am ready with my Foxy vision. We can make it happen by working together with all your effort and all your collaboration. Thank you very much for the patient listening, and thank you once again for being together on this today. Thank you very much.
I would request our chairpersons to give their expert comments on this topic.
And that was very fantastic description of what we have been facing. Actually, I'm happy to share that in Government of Tamil Nadu, all the CMONG centers are provided with SR cannula. So we are like having it in all our hospitals. So it's very useful and handy. So all the medical colleges, as Dr. Bailey sir said, it is very useful, and all medical colleges, all district headquarters hospitals of Tamil Nadu, government is supplied with the cannula. We have been provided with that SR cannulas. It is very handy. So now only it has been coming into practice by everyone. So those who are finished or they are not used to, I think they can use this opportunity of learning hands-on drill today, and they can have it in their PT. So that's very useful along with our uterotonics. So thank you, ma'am, for explaining in detail about what we are facing. So as you all said, we cannot prevent PPH, but we can prevent PPH death. So we should take a oath on that. Thank you.
We would also like comments of Dr. Radha Madhvi, our second chairperson. Unmute. Yeah.
Good evening. At the outset, I would like to thank Dr. Sadhana and wish her all the best. And she gave a very crisp and clear presentation, which was so wonderful. I just couldn't lift my eyes off the slides. She's made such wonderful slides. Hope it drives all.
Some net connectivity issues, probably.
Yeah.
Best wishes, Sadhana madam, and thank you, Dr. Babita, for calling and involving all our societies from Namakkal,
Welcome.
and Coimbatore, and involving all our in panel and the chairpersons. Thank you so much.
The pleasure is all ours.
Yeah, thank you so much. Thank you.
Okay, so ma'am, shall we move to the next? Yes, ma'am is there. So moving towards our next session, a speaker is Dr. Nalini Mishra ma'am, and it is a skill demonstration video on the management of refractory PPH. For this session, I would like to invite our chairpersons, Dr. Chandra Ponuswamy. She's president of Namakkal Obs and Gynae Society, and she's an IVF specialist consultant at Chandra Nursing Home and Fertility Center. She is founder president of Namakkal Obs and Gynae Society and faculty in many national conferences. A very warm welcome to you, ma'am. And our second chairperson, Dr. Hemlata, is secretary of I'm sorry. Dr. Radha Madhvi S. She is founder president of founder president of Tiruvannamalai Obs and Gynae Society and joint secretary and EC member TNFOG. She is director Rajaram Institute of Medical Science and has presented paper in AICOG and practicing gynecologist since 1994. A very warm welcome to you, ma'am. I'm really sorry. I would also like to invite Dr. Swati Rathod, whom I missed in the previous one. She is professor Department of Obs and Gynae in Christian Medical College and Hospital, Vellore. She has publications in international and national journals, and her special areas of interest being maternal and fetal medicine. So Dr. Swati Rathod was chairperson in the previous topic. I'm really sorry, ma'am. I had to take your inputs and somehow I missed it. Ma'am, are you there, Dr. Swati Rathod? She's not there. Okay, so let's move on with this session, and I request Dr. Chandra Ponuswamy to introduce Dr. Nalini ma'am, and I hand over the session to the chairpersons.
Yes.
Madam,
Yeah,
you call me instead of Dr. Swati.
kindly display the CV of Nalini Mishra, Tulika.
Thank you, Dr. Babita, for giving me this opportunity. And actually, really, I'm much honored, and I my wishes to Dr. Sadhana, dear friend, and also I am happy to share this platform with stalwarts like Dr. Paley, Dr. Sheila Ma'am, and others. And it's my privilege to introduce Dr. Nalini Mishra. She is Dean and Professor OG, Ellen Medical College, JK Super Specialty Hospital, Bhopal, and innovations to her credit: CG Balloon, innovative low-cost uterine balloon tamponade; CG Drake, an innovative low-cost Drake for estimating blood loss at delivery; and she has the innovative low-cost concept to rationalize the transfusion of blood products in PPH, published by IGJO, Figo House in January 2021. And she was the invited faculty in many conferences, and she has more than 50 publications to her credit, and citations she has more than 150. Now I call upon Dr. Naini to give her a speech on refractory PPH. As Dr. Sadhana told that everything, prevention is better than cure, and we all should anticipate PPH. Any case, any patient might go in for PPH, and we'll be doing every measures, but still we have certain cases of refractory PPH. Now she is going to enlighten us on refractory PPH. Please, madam.
Can I say something?
Yes, please.
Yeah, so first of all, my sincere thanks to Sadhana madam. She is my mentor, and she has given me this opportunity. And before we start the video, I want to just say that these drills which I am going to show here, these are for atonic PPH, which remains the cause for 70 to 80% of the cases. In all other cases, we have to find out the cause and treat. And because I prepared the drill as per the WHO technical committee consultation about this PPH care bundles. So in this, the section cannula and the uterine artery clamps and aortic clamps are not included, but Sadhana madam has already included these in her talk. So I just wish this conference and this webinar a great success. Can I go ahead with the this thing? Namaskar. From Bhopal. Today I'm going to discuss about the procedures which we do in refractory PPH. So what is refractory PPH? When the postpartum hemorrhage is not responding to the first line management, then we call it a refractory PPH. We all know how do we define postpartum hemorrhage. But when we talk of postpartum hemorrhage, we have to make a correct diagnosis. And to diagnose it correctly, we have to measure the amount of blood which is being lost accurately. For that, before I go to the management of refractory PPH, I'll just share a video of an innovative device, blood collection drip, that is Chhattisgarh drip. This is a drip which we can prepare at the point of care. You don't have to purchase it. It is very easy to make, it is very easy to use, and of course you can dispose it along with the other biomedical waste. So it is very environmental friendly, and it detects PPH in real time, and above all, the cost is very, very low. It costs around rupees 15 only. What things do we need for making this Chhattisgarh drip? Is basically it is prepared from this plastic apron which we all use, and apart from this we need a plastic sealing device which may be of any size. Generally we use bigger 18 inches plastic sealing device. We need a scissors, a marking pen, and a scale, plastic scale, which is already marked at 10.5, 12 and 15 centimeters. So let's see how do we make the Chhattisgarh drape. Yes, the plastic apron is already folded like this. It comes longitudinally folded. So we have to take the lower edge into the plastic sealing device and just press the upper bar over it, and when the sealing is completed, it gives a beep sound. It hardly takes 5 to 10 seconds. Then the lower portion of this plastic apron is converted into a cone, which is now put forward. Now this is marked at 10.5, 12 and 15 centimeter using this scale. This denotes the volume of 350 ml, 500 ml and 1 liter. The neck piece of this plastic apron is cut by scissors and is stretched a little. Now this is spread over the birthing surface, and the lower portion is folded and kept underneath the woman who is about to deliver. So during the first and the early part of the second stage. Now this belt which we tie on our back is tied on the front of the woman in the lower portion of the abdomen, and the upper belt which we have created by cutting the neck piece is tied over the upper portion of the abdomen. Now once the woman delivers and the amniotic fluid is all drained, and then we open this cone by asking the woman to lift buttocks a little, and all the blood which is shed during the separation of the placenta and after separation of the placenta can be collected in this cone. So this is about the Chhattisgarh. We also have to take into consideration the vital signs of the woman, particularly the heart rate and the systolic blood pressure, and the ratio of the two. The heart rate upon the systolic blood pressure is the obstetric shock. So whenever there is a diagnosis of PPH, we have to go for the PPH care bundle, as already been discussed. So the first response bundle it contains 4 components, that is uterine massage, oxytocic agents, tranexamic acid and isotonic crystalloid, preferably ringer. So we can remember it by MOTIV, M-O-T-I-V. Now then, and we have instituted the first line management, then we have to go for the second line intervention. And the second line intervention are covered under the refractory PPH bundle of WHO Technical Committee. So it comprises 2 compressions and 2 devices. So the 2 compressions are manual aortic compression and manual uterine compression. Then the 2 devices are intrauterine balloon tamponade device and non-pneumatic anti-shock garment. So the external aortic compression, as you can see in the picture, we have to stand on the side of the woman on a raised platform, ask the woman to relax, catheterize in advance, then on the left and to slightly at the upper edge of the uterus near the umbilicus, we just have to press with the fist. The thumb should always be outside so that the surface with which we are pressing is regular, and then you have to press it to the intensity that when you feel the femoral pulse on that side, the pulse can no longer be felt. So that is the manual aortic compression, and always take care to keep the hand straight. And this is a temporizing measure. Maximum time for which you can do this temporizing measure is 20 minutes, at the most 20 to 25 minutes. But in the meantime, we have to achieve the hemostasis, or we have to treat the cause of that postpartum hemorrhage. Second compression is the bimanual uterine compression. We all know that our closed fist goes into the anterior fornix, and then through the abdomen we just catch hold of the posterior surface of the uterus. It is compressed and elevated slightly. The uterus is compressed in between the two hands of the operator. So this is also a temporizing measure. It is painful for the healthcare provider as well as for the woman also. So this is we come to the uterine balloon tamponade. So when do we give uterine balloon tamponade? Ideally, whenever the obstetric shock index has crossed 1, but is still less than 1.5. That means the heart rate is more than the systolic blood pressure, but not 1.5 times more than systolic blood pressure. So there are many varieties of uterine balloon tamponade, and there are some commercial ones which are available, but they are costly and not available everywhere. So I'll be describing the Chhattisgarh balloon. And how do we make this Chhattisgarh balloon? Is we need certain things, and we have to prepare it at the point of care. It's not a commercial device, so we need certain things, and for that it is very important that we have the Foley's catheter of at least 22 French or 20 French in our basket of PPH, and then there should be condoms, then there should be 2 syringes of 20 ml preferably, not if not available then even 10 ml will do. There should be 2 big speculums, sponge holding forceps, Eurosec catheter, gloves, and of course the scissors and normal line. How do we make it? Make the CG balloon? We remember through these stages of A to F. So what is A? A is for air. So we instill at least 10 to 15 cc of air through the bulb inflation port into the bulb of the Foley's catheter. Then we just put it round our index finger of the left hand and burst the bulb of the Foley's catheter. So once it is perforated, insert the scissors into it and just cut it circumferentially all around the shaft of the Foley's catheter. Then the upper flap is everted upwards and the lower flap is brought downwards. The purpose is to expose the hole on the shaft of the bulb. Then comes the B, or making the bulb. So the condom is rolled over the proximal 1/3 of the Foley's catheter, and with the other hand we keep it at the tip. So the C is cutting the 2 rings from the urinary drainage port of the Foley's catheter. You can see we prepare 1 millimeter thick ring, and first ring is applied. So D is for double application. First ring is applied at the neck. You see that we have prepared a neck at the side, at the junction of the excised bulb of the catheter as well as the tip of the catheter. So you apply first ring, winding it around twice, double application, and then it is snugly fitted. The second ring is applied on the lower portion of the condom, 1.5 centimeters away from the rim of the condom. We have to take care that this does not wobble. This should remain straight. Then cut. E is for excision. Excise the tip of the condom and tip of the catheter together. There is a hole at the top. Then this creates the drainage port. Now put it in the betadine solution for 3 minutes and cut open a bottle of normal saline in winters, vomit. This is the CG drip which is depicting that it has bled more than 1 liter, and now the cervix is exposed with the help of 2 big speculums and with the help of with the help of 2 sponge holding forceps. Now this CG balloon is taken into between the 2 fingers, and it is introduced in the uterus. Having a conical apex, it goes easily, nicely it goes in till the rim of the condom is visible at the level of the internal os. If you want, you can put it even above that. This is done. Now after that, we have to pack the vagina. This is the biggest advantage of Chhattisgarh balloon, that we can pack the vagina before inflating the bulb, because we are seeing the ongoing bleeding through the in the urosec, tubing of the urosec, which we have connected to the urinary drainage port. Now, we have to inflate the bulb. So, take 2 syringes by while one is inflating the bulb, the other person is filling the syringe, and this way we keep inflating till we feel the resistance in inflation, and the column of the blood which we can see, which we now see in the tubing of the urosec, it stops moving. So whenever the bleeding is less than 50 ml per hour or within less than 1 ml per minute, roughly, so we can say that the hemostasis is achieved. Then the woman is catheterized, the uterine margins are marked, and she's put on oxytocin drip and on antibiotic. Now, if you want, you can prepare the Chhattisgarh balloon in advance and get it ETO'd and keep it in your labor room. You can deflate it 6 to 24 hours later. And for deflating, I prefer that we put a needle in the bulb inflation port, and then slowly it drains out, and then when we take out the pack, the balloon comes out after that. So if there is recurrence, before taking out the pack, we can re-inflate, but generally I never needed to. If one is not free, you could not prepare it in advance, and you are forgetting the steps, you can make a more simpler one, and that is easy balloon. So that is very, very easy. As you can see, we cut the 2 rings from the Foley's urinary drainage area and roll the condom on the proximal 1/3 of the catheter now, and you fasten it with the help of the ring which we have prepared already. So twice only, and we are not creating a drainage port here. So even staff nurses can make and use it. So this is done simply. We prepare it. We can prepare it within 10 seconds. And then again the cervix is exposed using 2 big speculums, and both lips of the cervix are caught with the help of these 2 sponge holding forceps, and then this is simply taken, and this easy balloon is more like a conventional condom balloon tamponade, only changes the way of fastening, which we have done by 2 rings cutting from the urinary drainage port. So we do not use any suture material. The principle is same. It is inserted till the rim is visible at the level of the os, and then here we cannot pack it. That is the disadvantage. And but here the advantage is that we can instill the fluid directly through the with the help of an IV set and the normal saline easily. And then the lower portion is folded once the hemostasis is achieved, and the second ring is taken, and we have to wound it round 3 times. This is the difference. This is 3 times. We just have to do it so that the saline doesn't come out, and rest of the precautions are same. And then when we have to deflate it 6 to 24 hours later, when the woman is settled, whenever we have to deflate, you just have to pull open the 2 ends and the saline comes out. So this is easy balloon. Now if the woman is not responding still, then we have to go for the 4th or the second device in the refractory PPH bundle, and that is non-pneumatic anti-shock garment. So before we go on non-pneumatic anti-shock garment, we have to make sure that the woman is catheterized and this NaSG is spread on the bed, so that the upper edge of the NaSG comes at the level of the lower rib of the woman. I have taken the video from YouTube, and then 2 persons tie various segments together starting from 1. So first is tied at the level of the ankle and is fastened with the help of Velcro, and you can put your finger and there is a snap sound. So we have to ensure the optimal tightening fastening of the segment. So first and second segments are tied, the ankle and the calf segment. Then third is the thigh segment, leaving the knee free to move, to bend. This is first, second and third. These are tied simultaneously by 2 operators, and then fourth may be tied by a single operator on the pelvic bone. So that is the fourth segment, and the fifth segment has a ball which is tied over the umbilicus, directly over the umbilicus, and is put in place by wrapping the sixth portion or the sixth part of the NASG. So that is done. Now this is the NASG in place. The woman should be able to breathe normally and should be able to flex her legs. Again I say, this is a video from the YouTube. So that is how NASG is there, and with NASG in place, the various operative procedures can be done through vagina, or if abdominal access is needed, then we can take out the abdominal portion. So for how long can we keep the NASG is, once she is settled, the etiology causing postpartum hemorrhage is taken care of, then we can remove the NASG. Then again it is removed in the way that first segment is removed first of both the legs, then we wait for 15 minutes. Then if she remains settled and her blood pressure does not drop by 20 millimeter mercury, or her pulse does not rise by 20, rule of 20, then we open the second segment. So, and again wait for 15 minutes, again check the vital signs, then third and subsequently all the segments. The hemostasis, we say whenever the bleeding is less than 50 ml per hour, we say that it is hemostasis. Once the NASG is removed, it has to be washed under running water, and then it is disinfected, and then it is wrapped properly for the use next time. So when at low resource setting we need to shift the patient, we have to transfer her with uterine balloon tamponade in situ. Uterine balloon tamponade is for atonic causes of PPH only. So uterine balloon tamponade in situ with non-pneumatic anti-shock garment, with IV line, with oxygen, and with a proper referral slip. You have to shift the patient to a higher center. When we talk of Chhattisgarh drape, CG balloon or easy balloon, these are all our local innovations and can be prepared at the point of care. There's nothing commercial about it. So I really feel very proud to be an Indian, and I thank you so much.
So we would like expert comments of our chairperson. It was a wonderful video presentation by Nalini ma'am.
Even in the low settings, we can prevent PPH. The video is a very good explanation for all these, especially those who are in rural areas and low setting areas. Actually, I congratulate Nalini for this. Any other chairperson with me?
Dr. Hemlata? No, Dr. Chandra. Chandra
Yeah, I
madam.
am Dr. Chandra Punsami.
Okay.
Yeah.
I'm here.
Dr. Radha is our chair.
Dr.
Yes.
Radha and
Madam,
Dr. Chandra.
Yes, yes. Madam, good evening and wonderful webinar you are conducting. And the more we can learn, so much we can learn from this, and it is like a revision to all of us. And I hope all the youngsters who are watching this will take it into their deep into their profession, so that they use it for all the situations. And Madam's presentation of that easy balloon was really very easy. Nothing is available, they can just do this very easily. And now I can only say in South, SR Canada has almost replaced balloon tamponade. because SR cannula is more physiological and the government is supplying it to all the PHCs and it's not very expensive also when compared to everything. And I think we should all start using SR cannula. And Sadhana ma'am's presentation, Nani ma'am's presentation was fantastic. Thank you for this opportunity. And Sadhana ma'am, all the very best for your elections and I hope you win. Thank you.
Thank you so much,
Yeah.
ma'am.
Yeah, I wish you all the success in your presidential election and you are a best deserving person. Actually, I used to read all your things. Though I'm a senior, I get revisions, everything. And again, once again, I thank you for this opportunity and also I wish you every success. Thank you.
Thank you. Thank you, Dr. Chandra, Dr. Radha Madhavi, for your precious word. Thank you very much.
So thank you, speakers, and thank you, chairpersons, for this wonderful session. Now, quickly moving forward to the surgical management of PPH, which will be presented by Dr. Shashi Kabra Maheshwari ma'am from Delhi. And for this session, we have chairpersons, myself, Dr. Babita Shukla, and we have Dr. Hemlata. She is consultant at RK Hospital, Namakkal, and is president of NAMOX. She is presently secretary of NAMOX Society. So, warm welcome to chairpersons.
Hello, madam.
Yes. I would request Dr. Hemlata to introduce Dr. Shashi ma'am.
Yes, ma'am.
Tulika, display the CV.
Yeah, good evening all. I am Dr. Hemlata from Namakkal, NAMOX Secretary, Namakkal. I welcome Dr. Shashi Kabra Maheshwari. She's an MD FIOG. He's a senior specialist and NBE teacher in DDU Hospital, Delhi Health Services. President, Delhi Gynae Forum, Southwest. Chairperson, PCP Entity Committee, West District, Delhi. And she has won a lot of awards and all that. Yeah, thank you, ma'am.
Thank you, ma'am. We can start.
Thank you. Yes, ma'am. Yeah.
Is my screen visible?
Yes, ma'am.
Yeah. Thank you so much, Dr. Sadhana ma'am. Thank you, madam, for the kind introduction. And thank you to Dr. Babita Shukla and Ayushi Agarwal ma'am and all the societies, Vellore, Coimbatore, Namakkal and Thiruvannamalai for making me a part of this prestigious teaching program. So I always start my presentation with the words of Dr. Ian Donald, very important. While managing postpartum hemorrhage, time elapsed should not be counted in a minute. One has not lost 1 minute, but 60 seconds. So coming straightway to the surgical management, when the balloon fails, then we can apply the compression sutures. 3 commonly used compression sutures are Belinch, Heman. It is done when patient is opened after vaginal delivery, and Cho's suture. Regarding the suture material, Dr. Belinch previously used to use number 2 catgut, which is still used whenever it is available. Then bicryl number 1, and recently he had been using monocryl, that is polyglycapron 25 also. The one important thing is that the length of the suture should be around 90 to 100 centimeter, because in one go we have to take the whole suture, and the needle thickness is 70 mm, and the needle point should be round, because if it is cutting, then it will pierce and cause bleeding. The position is best Lloyd-Davis position, and bladder should be catheterized. But if this position is not available, even in supine position, we can perform this. So showing you a video of Belinch sutures on the model.
Good afternoon. Compression sutures on the model of the uterus. This is an educational model of the uterus, and I give sincere thanks to Dr. Sheila Mane, who has given me this educational model for teaching purpose. And it was made by Sir Christopher Gill. This is the anterior side of the uterus, showing the LSCS incision, upper flap, lower flap. This is the cervix, and this is the posterior side. Now, before applying Belinch sutures, we have to confirm whether the suture will work or not. So we have to exteriorize the uterus, put one hand on the posterior side, one on the anterior side, we have to compress like this, and we have to see if the bleeding is reduced. If bleeding is reduced after applying this pressure, then we can presume that this suture will work and we can proceed with these sutures. Now, what suture material are to be used, I have told you in details in my presentation. Here I am using catgut number 2, 90 cm length, 70 mm thickness, blunt round body needle. So let's proceed with the sutures. So we have to identify few points. On the anterior side, this is the LSA scar. There is point A, 3 cm below the lower incision and 3 to 4 cm medial to the lateral side. Then we have point B, 3 cm above the upper part of the incision and 3 to 4 cm medial to the lateral side. And similarly, we have point E and F on the opposite side. And we move the uterus posteriorly. Then we have point C, which is just behind the location of point E and point A and B. And we have point D, which is just behind the location of point E and F. And they represent the site of insertion of the uterosacral ligament. Now proceeding with the sutures. This is point A, 3 cm below the lower flap. I am going from outside to inside at the lower flap and enter the uterine cavity. Then from inside to outside I am coming out through point B, which is 3 cm above the upper uterine flap. Now my assistant will help me and I will curl around the fundus. This distance is 4 cm medial to the uterine column. Hold it like this. This is point C. Now I will pierce from point C and will come out anteriorly in the uterine cavity. Now I am inside the uterine cavity. Again I will pierce through point D and will come outside. So this is the location of point D. And I have come out outside posteriorly. Assistant will again help and he will keep on compressing the uterus. Now I will enter the uterine cavity again through point E. And will come out again through point F. Assistant will throughout keep the uterus compressed and now we hold it. Then the uterine incision suture is to be closed and we have to take utmost care of the angles. And now I will tie the sutures. Keep it compressed. First turn, second turn.
There should be 2 throws in the first knot. Make the knot square.
This is second suture and this is third suture. So it will look like this and we can cut. So this is how the benin suture will look anteriorly and this is how the benin suture will look posteriorly.
I am not showing Heman and Cho suture because of lack of time. And now I am moving to staples devascularization. All of you know that we ligate the uterine artery at 2 places, upper and lower, and when we ligate the anastomosis between anastomosis of the uterine branch of ovarian artery and ovarian branch of uterine artery, the place of ligation of anastomosis is at this place. Ovarian artery ligation is a misnomer. We do not ligate the ovarian artery. This was a video made by my colleague, which I'm showing you. Cesarean section has already been done, bladder pushed down, and I'm palpating the uterine artery. Two centimeter of the myometrium taken. The ligation of uterine artery always includes myometrium. Taken the needle out posteriorly. Then look through a avascular window in the broad ligament. Needle brought anteriorly. First knot should always be a surgical knot. That means 2 throws. Distal ligation is 2 to 3 centimeters below the proximal ligation. And similarly, we repeat on both the sides. Now I'm showing you the ovarian artery ligation. I usually use 1-0 Vicryl here, because in upper part of the fundus, the myometrium is thicker, and sometimes bleeds on using number 1 Vicryl. Going through the avascular window. This is actually the anastomosis of the uterine branch of ovarian artery and ovarian branch of uterine artery. And the place of ligature is just medial to the attachment on the ovarian ligament at the uterus. And similarly, we repeat on the other side. Now, coming to the internal iliac artery ligation. Remember one thing, all this step-wise devascularization is the method when we use when the patient is stable, and all these are the conservative methods of treatment of PPH. So just going back to our anatomy classes in first year, this is abdominal aorta, the biggest vessel of our body, divides at the level of L4 and 5 into 2 common iliac artery, and each common iliac artery further divides into external iliac and internal iliac. So we are concerned about this inverted Y, not this inverted Y. So we are supposed to get 2 inverted Y on both the sides. This is a smaller inset picture of the same. This is of one side, this is common iliac artery. Divides into external iliac artery and internal iliac artery at the level of sacroiliac joint, and this internal iliac artery immediately after its origin gives the posterior branch, and we have to ligate the anterior division of the internal iliac artery because the major supply is to the uterine artery and vesical artery. So how internal iliac artery works? Bilateral ligation results in 85% of reduction in pulse pressure. We should always do bilateral ligation because the chances of morbidity and re-laparotomy increases when we do unilateral internal iliac artery ligation. There is a 50% reduction of blood flow, and arterial flow converts into venous flow, and this facilitates coagulation, bleeding is reduced, and life is saved. So these are the 2 important things which are concerned with this ligation. One is this instrument called right angle forceps or mixture forceps, and this is the double thread. We make a thread double. I usually use silk, but if it is not available, one can use Vicryl. So this is the model, the 3D teaching model, which I made for demonstration of internal iliac artery ligation, because I felt the need that the students should learn it outside the patient's body so that they do not make mistake inside. So just showing you a video.
This is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and we have to ligate the anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize.
You see, at this time, already posterior division has been given.
This is right angle forceps, also called mixture forceps. It is bent at 90 degree and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath around the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath.
Yeah.
Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle forceps from lateral to medial.
Remember the word lateral to medial.
Gently I will open it.
And the loop will be prepared beforehand, double thread.
And just gently I will come out like this.
You have to be very gentle in your movements.
This movement is very, very gentle. Now next step is, I will cut this and make 2 threads. And this is another thread. See, this is plain and this is another thread.
Just check whether
So
the threads are plain.
Technique of applying ligature. I have taken hold of one ligature. I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand, and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying now. This is one turn and this is second turn, and I have tied it here. Then very gently I applied the second throw.
You have to literally nail. You can't lift the artery up.
Again very gently I applied that.
I bow my head on the superior surface of the artery.
Without pulling the artery, I myself cut this. Just without giving any pull on the suture, I'll cut this. I'm just putting this. This is common.
So now I am showing a video on a live case. This case was a case of massive traumatic PPH, broad ligament hematoma, received in my hospital 12 hours after delivery, and I had to do a hysterectomy. And you can see here, this is the round ligament ligature, and now I'm proceeding for internal iliac artery ligation. So just below it, I'm opening the anterior broad ligament, anterior part, anterior peritoneum. Actually, we call it retroperitoneum. When we cut this, then we go behind and we see the vascular area, and the movement is towards the lateral pelvic wall. And you see, every time I'm seeing and lifting the thin peritoneum, because there is a danger of injuring the big vessels over here. Now I've kept my instrument aside, and only with the help of 2 fingers, I'm opening and enlarging the loose areolar tissue. So the retroperitoneum is opened, and now I will try to locate the. And you just follow the things which I've shown in my model. Just see. I'm not using any sharp instrument here because I know that this is a area where big vessels are lying. This is my unedited video from opening to ligature. Time was not edited, only name were inserted. Now you see, gradually the vessels are becoming prominent. You can see this is ureter in the medial flap. This is internal iliac artery, and the other one is external iliac artery. And you can also appreciate the common iliac artery. I am defining my dissection a little bit more, only with the help of my fingers, because they will not injure any structure. Now you see, this is common iliac artery. you can very well appreciate the inverted Y. So the structure which is near to ureter, that means medial side, that is internal iliac artery. Now, it has been made prominent. This was a real case brought to me after 12 hours. Now I am pressing the external iliac artery and palpating the femoral. The pulse will have changed. On pressing, it will go, and on releasing, it will come. Again, I am reconfirming by pressing the internal iliac artery. And when I press the internal iliac artery, I do not find any change in the femoral pulsation. So it is double confirmed that this middle structure is internal iliac artery. It is very important to recognize the structure before operating on it. Now the double thread is ready. Before passing the right angle forceps, you keep the double thread ready along with the loop. Now look at the type of dissection which I would do. You can see the psoas muscle below. Now this is my right angle forceps. Its tip is not sharp. And 3 centimeter I've shown you with my thumb length, folded thumb length. Just below 3 centimeter below the bifurcation of the common iliac artery, I'm doing the dissection. Because if we do dissection along the whole length, that at every place, we will increase the chances of injuring the internal iliac vein. So you just see, I've localized my place where I have to ligate the internal iliac artery. And this thin sheath is just separated like this. And the movement of my instrument is parallel to the vessels, not perpendicular. I made a space for my ligature. Gradually, I'm making it. And this place is 3 centimeter or length of my folded thumb below the bifurcation of common iliac artery. Because in reality, you cannot see the posterior division in pool of blood. You see, that part of artery is now well exposed where I have to apply my ligature. Now look at the movement of the right angle forceps. As I've said, lateral to medial is the word. Because if we go reverse, then we will injure the external iliac artery, vein, external iliac vein. So from lateral to medial, I pass my mixture forceps. Loop is already ready. No time to be wasted here. In getting the loop, I got hold of the loop and very gradually and gently pulled it towards the side. Now, the suture has been cut and we have made 2 threads from 1 thread. Why? Because we do not want to pass right angle forceps twice, because we will increase the chances of injuring the internal and external iliac vein twice. So in 1 thread, we make 2 threads. That's why we double the thread. Now, very gently, I will separate the threads to check their continuity. This is an unedited video, I'm repeating. Real case situation. If you have any doubt, just take it again. This is what I'm doing here. And now I've recognized and I'm applying the knot. 2 throws in first knot. Go on to the superior surface of the artery. Never pull the artery. So the first ligature has been applied. We have to apply 2 ligatures on internal iliac vein. It is a very big vessel, and we never cut it in between. We just apply 2 ligatures. The second ligature should be 0.5 to 1 centimeter away from the first ligature. very well you can appreciate the inverted Y and the ligature in place. Now I'm applying the second ligature, and I will keep it 0.5 to 1 centimeter away from the first one. Again, going up to the artery, bringing my hand up to the artery, not pulling it. You can see the distance very beautifully seen, 0.5 to 1 centimeter between the two ligatures. And when I cut, I never pull the thread. Without pulling the thread, I cut it. So now you can see the ligature in place, and just see that there is no extra bleeding here. So this is the right technique, moving it from lateral to medial, not from this side, because it will hit the external iliac vein and injure it. Now, these are my own tips of performing, which I made after performing 101 internal iliac artery ligations. Open the retroperitoneum from round ligament to infundibulopelvic ligament, or this is called anterior approach, and in posterior approach we have to make a nick on the retroperitoneum 2 centimeter below and 2 centimeter lateral to sacral promontory. But I love doing it from anterior approach, and I almost always I can do it. Then do only finger dissection as I have shown. Locate the bifurcation as I have shown. Recognize internal iliac artery as a medial structure which does not cause any change in femoral pulse. I have told you. Then movement of mixture is always from lateral to medial, and careful knot tying in the cavity. Don't pull the artery, go up to the artery, and two ligatures 0.5 to 1 centimeter apart, and always do bilateral. Now coming to obstetric hysterectomy, we should think of this sooner rather than later, and we need to perform it fast. And remember one thing, there is no use of saving the uterus and losing the mother. So we can perform subtotal hysterectomy in those cases which have atonic PPH, and it is very easy and fast. And for total hysterectomy, if there is rupture of uterus extended to vagina, placenta previa, placenta accreta spectrum, massive wall tear, or uncontrollable bleeding from colporesis, in these conditions we need to total. So I feel that an obstetrician should know both the total and subtotal hysterectomy. When we already anticipate problem, then it's better that we open the abdomen by a vertical incision. And suppose a transverse incision has been given, then we can convert into a modified Mallard incision, or sometimes we have to add a vertical T. This is a case of placenta accreta spectrum, in which I performed a total hysterectomy. You can see the last clamp below the cervix, and this is the picture of the cut uterus. You can appreciate your placenta percreta. So now a situation arises when hysterectomy done, internal iliac artery ligation done, is still oozing from the abdomen. So what else can you do? Drape sheet, complete. You can drape the abdomen with a complete drape sheet, or multiple mops tied together, or Surgicel or gel foam. Depends on the amount of bleeding. I have used all of them many a times. And remember one thing, drape sheet if you introduce, or mops if you introduce, and after 48 hours you have to reopen when the patient becomes stable, and then you have to remove this. So the take-home message is every obstetrician should know any one type of balloon tamponade, at least any one type of brace suture, at least both subtotal and total hysterectomy, at least subtotal hysterectomy, and every obstetrician should learn IL. This is high time that we all should learn IL. Thank you so much for giving me this opportunity and for listening.
Thank you, doctor. It's a very enlightening program. And I never do any internal iliac artery. We have done B-Lynch. That's all. It's a nice thing. Whatever you said, the take-home message is very good, that we all should learn how to go about doing proper hysterectomy and iliac artery, internal iliac artery ligation. It's a very nice program, and congratulations to you for doing so many procedures of internal iliac artery ligation, doctor. Thank you for so much. Yeah.
Thank you.
Anybody else wants to ask any questions to doctor? Hello.
Yes, ma'am.
There is a question. There is a question from
Yeah.
Dr. Santya Nandini. Kindly explain about short stitch.
About?
Short stitch.
Okay. So basic, I have a video. Can I show this?
Yes, ma'am.
Okay. But it will take little time because I had removed it from my slides. You can continue with Dr. Josna Suri's panel, and after that I can show you my video on
Yes, ma'am. Yes, ma'am. Yes, yes.
Okay, yeah. So
Yes,
it
yes.
will not waste time.
So, ma'am will show the suture. Let's quickly cover a panel discussion. For this, I would like to invite our moderators, Dr. Josna Suri. Ma'am is in the Department of Obs and Gynae, Vardhaman Mahavir Medical College and Safdarjung Hospital, VNMC. And our second chairperson, moderator, we have Dr. Siba Marwa. She's Associate Professor, VNMC and Safdarjung Hospital. She's got a very, very impressive CV. She's a co-critical care obstetrician team member at VMMC and Safdarjung Hospital and DQM training division of quality cell team at the same hospital. She's member labor room quality care team of Lakshya at the same hospital and course faculty for critical care course in ops by DFS and co-editor AOJD Bulletin 2122. She's got 16 international and national publications to her credit and recipient of numerous awards. A very warm welcome to you, ma'am. We hope for a wonderful panel. I would quickly like to invite our panelists for this session today. We have Dr. Richa Sasmita. She's Associate Professor at Christian Medical College, Vellore. Dr. Varuna Sri is Assistant Professor at Christian Medical College, Vellore. Dr. Murughlakshmi, she is Professor Obs and Gynae in the Department of Obs and Gynae at Coimbatore Medical College. Dr. Silambuchelvi, Madam is Managing Director at Vansam Facility Center. Dr. Jayanti is the Chief Civil Surgeon and District Chief Officer at Namakkal. And we have Dr. Sri Devi from Namakkal. A very warm welcome to all our panelists. We look forward to a wonderful panel discussion.
Yeah, so hello everyone. So Dr. Shiba will be sharing the slides. Shiba, can you share the slides?
Yes, ma'am, I'll do that. Ma'am, actually the previous slides have to be shared.
So you have to stop sharing the screen.
Ma'am, we have expert Dr. Bharati also.
Yeah.
Oh, yes, yes. We have expert panelist with us, Dr. Bharati Rajshekhar. Madam is Medical Director and Ops and Gynae Consultant at Vatsalya Hospital. She's Honorary Secretary General, Kasoga 2123, KPMEA State Vice President, and Madam is has held numerous important positions in the society in the past. Foxy Public Awareness Committee, South Zone Coordinator, and a special interest are adolescent health, high-risk pregnancy, and family welfare. A very warm welcome to you, ma'am. We look forward to some very useful inputs from your side.
Ma'am, can you see the slides?
Yeah, we can see.
Yes, visible.
Full screen now, Shiba.
Yes, ma'am.
So we want to thank Dr. Sadhana Gupta for giving us this opportunity to moderate this session of unusual and challenging cases of PPH, which we have all managed in our hospital in Safdarjung. These are all real cases. So Shiba will take over.
Yes, thank you, ma'am. Thank you for the kind introduction to Dr. Babita Shukla. And I am feeling extremely honored to be in this August gathering with my mentor, Dr. Josna Suri ma'am, who's the in charge of the critical care obstetric unit at VMMC in Safdarjung Hospital. We have a great gamut of panelists here, and the introduction of all has already been done. And we also have an expert, Dr. Bharti, and we really look forward for valuable inputs. So most of the PPH has already been covered by the previous stalwart speakers, and now we are here to quickly take you through a panel where we will give the crisp take-home messages which we got from sharing the experience by handling few of the cases in our obstetric HDU. So let's get started. Maternal mortality, as we all know.
Can you make it full screen? Is it full screen?
No, it is not full screen.
Yes, ma'am. I'll just do that. Is it full screen, ma'am?
No, we can see on the top your, the inbox PPH panel. I don't know. Maybe nahi ho raha full screen. So otherwise we'll continue like that. No problem. Agar hota hai to kar do. Just try if it's possible.
Okay, ma'am. I'll just try again. I'll share the slides once again, ma'am.
Is it okay, Shashi? You can see the slides.
Yes, ma'am. It is okay. It will work. It is okay.
Chalo, we continue. Shiba, you can continue. Yeah.
Okay. I think I should share again. Then it will be visible.
Chalo, just do it quickly if it's.
Yes, ma'am.
So we have actually had a wonderful session of PPH. I saw all the videos of Dr. Shashi, and then, it was really Dr. Nalini, wonderful videos, and Dr. Sadhna's talk. So it is basically whatever we are going to be doing in this panel. It is putting together all that knowledge we have had into, the way how to manage the cases. So it is going to be very useful to especially our resident doctors and our young obstetricians who are practicing, because these are the real cases which come, and then, the sequence of how we are managing them, especially the challenging cases, which Dr. Sadhna especially said that take different kind of cases which you have managed in the hospital. So we have taken 3 such cases.
Yeah, now slideshow has come.
Yeah, now it is slide. Now it is full. Yeah.
So let's get started. So maternal mortality, the WHO fact sheet of 2019 says that every day around 810 women die from preventable causes which are related to pregnancy and childbirth. And in India, the maternal mortality ratio is quite high. When we analyze what are the causes when the pregnant women are dying, from which the pregnant women are dying, the hemorrhage is the leading forerunner, because it forms a part of the deadly triad of maternal mortality along with hypertension and sepsis. So what is PPH? We have already been told that bleeding from genital tract more than 500 ml after vaginal delivery and 1000 ml after cesarean section is PPH, and it is classified as minor PPH and major PPH more than 1000 ml, which is further classified into moderate and severe. And the 4 causes of PPH, we all know about it. That is the atonic PPH, the traumatic PPH, the PPH because of the retained products, and also because of the thrombin or the coagulation disorders. So immediate and adequate action is required, because if untreated, death occurs within 2 hours. So the golden hour of resuscitation is all what we are here to emphasize upon. And so the road to patient safety in obstetrics goes through, and it goes to safe motherhood, but we often face the challenging roadblocks, and out of which the 3 of them we are going to present here. So I hand over to Dr. Josna ma'am for taking us through first case.
Okay, thank you, Shiba. So the first case was a 22-year-old primary gravida who came at 35 weeks period of gestation with complaints of yellow discoloration of eyes and urine since last 3 to 4 days and vomiting for the last 3 days. She was also complaining of labor pains for the last 4 hours. So on examination, it was seen that her BP was slightly on the higher side at 130/90. Respiratory rate was also higher at 26 per minute, and SpO2 though was normal on room air. So we found the uterus to be irritable. Patient was in early labor. So yes, next slide, Shiva. So when her investigations were seen, the immediate emergency investigations were done. So it was found that she was anemic with a hemoglobin of 8.4. TLC was on the higher side and total bilirubin was 12.6 with AST ALT of 544 and 344. And the KFT was also deranged with a creatinine of 1.7. RBS was on the lower side at 67 and the coagulation report revealed a INR of 2.7. She already had viral markers with her, HBsAg, anti-HCV and anti-HAV, as well as the anti-HEV. So all of them were negative, and ultrasound was done on arrival in the emergency, which showed single live fetus at 34 weeks with the placenta upper posterior, and there was mild ascites, and there was a comment on the bright liver and a right pleural effusion of 1 centimeter. So this was the scenario, which we found in the patient. So our first question is to Dr. Richa, that when such a case comes, what would be your provisional diagnosis and what would be your main concerns, about that kind of a patient? We have seen that she's a high-risk patient. So what would be your concerns for this? Dr. Richa, are you there? I think Dr. Richa is not there. Is she not there? Shiba, did we?
She was there, but I think so there is some connectivity problem at her end.
Okay.
So we can ask this question to our next panelist, ma'am.
Ma'am, am I audible?
Yeah, you're audible, Dr. Richa, but your voice is echoing.
Dr. Varuna?
Yes.
Acha, I think Dr. Richa is okay. I think we can give it to another panelist, and Dr. Richa can be asked another question. Is it okay? Dr. Varuna, can you take this? Her voice is also echoing, is it?
Good evening, everybody. Thank you for giving me this opportunity.
Yeah.
What is my provisional diagnosis is, I'll be taking first as a AFLP. Next will be the diagnosis differential. One of the thing is like ELP. With the preeclampsia, ELP, which is going to lead to the hepatic thing. So that will be my second differential diagnosis. So third, if it's actually because of the ELP and preeclampsia as a background, irritable abdomen and all, one I can take into the consider of having it as a abruption placenta also.
Okay. Okay. So yes, so very well answered. So, and what about the concerns we have for this patient?
From Velo, we are at the same place, so we just like to add in. Ma'am, am I audible?
Yes.
Yes, Dr. Richa, you are audible.
Thank you so much. So here, first, my professional also would be, as I would agree with upon Dr. Varuna, saying that the weeks of gestation where the lady has presented with is about 35 weeks, and very classical symptoms of yellow discoloration and vomiting. On examination, uterine BP, like ma'am also highlighted, was slightly on the borderline. So some of the AFLPs are also known to have hypertension, but maybe not but many do present with some hypertension background.
50% of them do present with hypertension.
The
So that
liver
is a supportive diagnosis, definitely.
creatinine levels, the RBS being low, and borderline this coagulation parameters, these are, and most classically the bright liver, which is seen in the ultrasound, is all pointing the most probable diagnosis to be of acute fatty liver of pregnancy. Would go with that, ma'am.
Yeah, very nicely put, Dr. Richa. Yes, you have told that why you have thought it to be AFLP. And yes, so the concerns for the patient that she is having AFLP, and we all know that AFLP has got a very high mortality, and she's already gone into labor. And with such a high INR, we are very worried that she is going to end up with PPH, so that is what we are all here together discussing today. So this is a patient in which we are very worried that she will have PPH. She's having a deranged coagulation, and already her baseline hemoglobin is also low. So other complications which we see in AFLP, you have just highlighted. So this patient was already in the malls, yes, and she's in acute hepatic failure, as well as hypoglycemia and DIC. So next slide, please, Shiva. So with this case, then this case came last month to us. So we directly admitted her to our obstetric critical care unit, and the labor progressed spontaneously, and she delivered a term live male child of 2.5 kg by normal vaginal delivery. And the active management of third stage of labor was given. But then, as expected, patient had PPH. It was a atonic PPH in the beginning. She lost about 800 cc of blood. Yeah, next please, Shiba. So now in this case, what are the methods by which the blood loss can be estimated, and why is it important? So this has already been covered very nicely by Dr. Nalini. We have seen it, but quickly, if you can tell us that why, why we have to estimate the blood loss, and what are the different methods? Just a revision, quick revision. Yeah, Dr. Varuna, that was for you. So both of you and Dr.
We will be able to estimate in the labor room, like visual assessment. It's like the amount of mops you use, and we usually use underpads for the delivery patient. So our underpads is around 500 ml, and each mops is around 50 ml. So why the visual assessment is a better thing. Then the next track, as in the normal delivery, it's always you can have an interaction with the patient, and you can ask your colleagues to get the vitals checked, heart rate, blood pressure. And when you go talking, if the patient feels dehydration and all, you'll know that, patient is in the not going to the shock, but in the process of, when the patient is not responding, then you'll know that patient has gone to the shock. So these are the two ways we can assess the blood loss.
Yeah, thank you, Dr. Varuna. So Shiba, you can go ahead with the slides. Yeah, you can see all these, methods are there. If you can go back to the last slide, Shiba. No, the clinical. Yeah, so you can see by this, that the grading of blood loss, we can do class. There are 4 classes, and even if we have not been able to estimate the blood through the visual aids and other methods, we can actually, have some idea with this, that how much volume has been lost. And one important thing is that hemoglobin and hematocrit, in the first 4 hours, it is not a reliable method to see how much blood has been lost, because it takes minimum of 4 hours for the hemoglobin to drop. And ideally, normally the nadir is at around 48 hours. So we cannot assess, blood loss by hemoglobin in the early shock. So that is one mistake very commonly done by the juniors, that the hemoglobin is normal, so she cannot be in shock, or she cannot be losing blood. So this is important for us. So now what should be the immediate management? We have seen she's already had PPH. And what is the bundle approach, and how does it help? Dr. Muruga Lakshmi?
Yes, ma'am. Now we have to start the resuscitation immediately. Here we have to tackle the 2 T's of primary PPH. That is, one is thrombin is deficient because of AFLP, and number 2, it is atonic. So we have to start simultaneously, replace it with blood and blood products has to be done. And also we have to give oxytocin. Here carbetocin plays a main role because carbetocin also promotes coagulation. So that thing has to be taken. And the bundle approach here is mainly that is primary, that is bundle approaches, motive, gentle massaging of the uterus, oxytocin, tranexamic acid can be given. Then we have to go for IV fluids. Here we can also go for blood and blood products, since we know this patient is an high-risk patient with deficient coagulation factors being deranged. So for this, we need blood and blood products has to be replaced. If it is refractory to this first bundle approach, then we have to go for, that is your compressive measures, as Nalini madam told, two devices and two this compressive measures.
Thank you.
Aortic compression and bimanual compression. And we can go for this, that is, if intrauterine balloon tamponade can be given, but that should be with a draining port should be there, or else we can go for the suction cannula, which promotes physiological method, because that makes the uterotonics act on the uterus. But if you go for balloon tamponade, the oxytocin what we give may not reach the uterine bed. Then the other one is your NASG suit can be, if at all, if you want to transfer her, we may use the NASG suit, that is your non-pneumatic.
Yeah, thank you. That was very well answered. But I think carbetocin we would not be using at the moment for management of PPH. We only use it for the prophylactic, for prophylaxis, that is for the active management of third stage. But as of now, we are not using for the management of PPH.
If carbetocin is not available, we can go with oxytocin. And
oxytocin is the drug of choice for PPH.
Yeah.
Once PPH has occurred, then carbetocin we are not using. It is not yet, we are not authorized to use carbetocin for management. We only use it for the prophylaxis. So that is an important message, because the regulatory authorities do not allow us as of now to use it for the management. So this, Shiba, that's a good slide of pin girl, which we use very often when we do the PPH drill about the head end, at the arm end, and at the perineum, what all activities have to be done. So the time doesn't permit us to talk in detail. Next, please. Yes, bundle approach, you have already told that you have to do the first bundle and then the second bundle. And of course, yes. So next, please. Yes. So the uterine tone was reassessed and it got well contracted, but still there was a mild trickle. And by now the estimated blood loss was 1000 ml. And vitals, however, remained throughout normal, and the urine output was also maintained. Yes, next, Shiba. So, Dr. Silama Bulchelvi, what would you like to do? What is the role of balloon tamponade? So, little bit has been mentioned already. Would you like to elaborate a little bit more about the role of balloon tamponade in this case? Do you normally put a prophylactic balloon tamponade in such cases, or we wait for PPH to occur?
No, madam. Good evening. Thank you very much for the opportunity. You told very clearly she is a case of atonic PPH, and that was well managed by Dr. Murugalakshmi. In spite of that, she is bleeding. So even after bundle management, bundle approach, she is bleeding. So she is a case of refractory PPH. So again, Murugalakshmi told about the abdominal compression, bimanual compression, and balloon tamponade, and it was well demonstrated by Dr. Nalini. And actually, earlier it was the uterine packing that was totally replaced by balloon tamponade. Paili sir, in his introduction, he told the suction is far better than the balloon tamponade, everything. So, but in low reserve settings, definitely it has a place when we buy some time for shifting the patient to theater or to the higher center. We can minimize the bleeding by compression from inwards to outside, and also by the hydrostatic pressure of the balloon on the uterine arteries. So, I mean, commercial balloons are also, balloon tamponade also available. Like Foley's catheter, condom Foley also can be made on our own.
Yeah, thank you very much. I think that gives us a very comprehensive answer. So next, please, Shiva. Yes, so these are the different types. They have already been discussed at length. Yes, and how long would you keep the balloon tamponade? How long would you like to keep it?
So usually 4 to 6 hours. Sometimes we have to keep it for 24 hours, and the deflation is 20 ml per hour, like that. Sometimes after 20 or 12 hours, we can remove 50% of the fluid. So normally we inflate 200 to 500 ml. So if we are deflating by 20 ml per hour, it takes sometimes 24 hours. So we can keep even up to 24 hours.
Right, absolutely. Depending on what is her platelet level and what is her hemoglobin, we
and
can
also the response of the patient.
Yes, absolutely. So despite the uterine tamponade, now the patient continued to trickle. So as initially also told that she is a case of coagulopathy, so we had made the active, management, active intervention of arranging the blood and blood products, but it does take time. So, but now, by now, after 1 hour also, she is trickling. So now we would like a very specific question from Dr. Jayanti, that how do we manage this coagulopathy in such a high-risk patient like AFLP?
Good evening, madam. Thanks for giving me the opportunity. Like even after giving all this medical management, uterotonic and balloon, still the patient is bleeding. In this case, it's mainly because of the coagulation factors deficiency. So we have to correct with coagulation factors and blood products that will help her for the uterine contractions as well as the bleeding trickling to stop. In this case, can we use tranexamic acid, madam? I think that will be of much useful.
Yes, actually, if we have got the ROTEM with us, that gives us a very good picture of the dynamics which are taking place during PPH. So, it gives us that which is the most important component which is giving rise to the bleeding, whether it is the deficiency in the platelet or the fibrinogen.
So, mainly in the case of liver failure, we have to replace the coagulation factors.
Yes, but tranexamic acid,
that can be very helpful for this.
If it is the antifibrinolytic action we are looking for, so tranexamic acid can be given, but it can in DIC be a double-edged sword, because then it can also promote thrombosis in the small vessels and further lead to the organ dysfunction. So it is a double-edged sword. Tranexamic acid is something which we have to give very carefully, especially in a case of DIC. If you have the ROTEM with you, it is very easy to know which one to be given. But one dose and all won't make much difference. But repeatedly giving is a bit of a dicey situation. Yes. So besides that, then what are the blood products and how many you would like to replace, madam?
We can give a blood transfusion. Minimum coagulation factors, factor 9 can be transfused. Minimum, I think at least 5 packs we have to give.
Yes, and so we may need to give the massive blood transfusion in these kind of cases.
Platelets.
Yeah, we have to, because
isolated platelet transfusion and coagulation factors, which will be very much helpful.
Yes, so this is a very important slide in which we see that
FFP.
Yes, what are the different components, and here what is the trigger and what is the increase? Yes.
We can do a Paxil transfusion, and FFP can be transfused, and isolated platelet transfusion, and cryoprecipitates, and fibrogen concentrations can also be transfused.
Yes. So we can see here that for platelet, one platelet, the random donor platelet, will increase only by 4 to 5,000. So if we get the apheretic unit of platelet, then we can increase straight away with 50,000. And as far as because this patient had a very high INR, so we need to give FFP to her. And FFP, we give 10 to 15, milligram per kg body weight, ml per kg body weight. So here in this case, we had given her the FFP, but still she continued to bleed. And here we had given her the fibrinogen concentrate. So this patient was managed with fibrinogen concentrate. I'll show you the slide. So can you show, Shiva, what is the fibrinogen? Next one, please. Yeah. So this is, the fibrinogen. We are getting the lyophilized fibrinogen these days. And luckily, we had this stock with us. It is very expensive. For one patient, you may need 60 to 70,000 worth fibrinogen. And for this patient, it worked. It was there with us, and we gave, and we could stop her bleeding, and she survived and went home. After 1 week in the ICU, she had to be intubated also for encephalopathy later on, but we could extubate her, and then she survived and went home. So it was, I think, fibrinogen did contribute towards her survival, because at one stage after FFP also she was trickling. So this, fibrinogen is very, you can keep it in your fridge. Like other blood products, you have to arrange, you have to order, you have to, take help of the blood bank. Your blood bank may not have the FFP, and then large volume is given if you give FFP. So here in smaller volume, you can immediately give, like, over 10 minutes, like you give any other drug. So the advantages are there, of course, with fibrinogen, but major limiting factor is the cost. And of course, there is small risk of thromboembolic events also. Even with the factor 7A, it is not given much in PPH because of the risk of thrombosis. So this is something which is the last resort drug, basically, the recombinant factor 7A. So the patient delivered, and we know AFLP, the treatment is delivery, whether we do it by vaginal delivery or cesarean. So Dr. Shri Devi, what are the precautions, during delivery in such patients? What all would you think about, and what would you do, extra for such patients who are in coagulopathy?
Good evening, madam.
Good evening.
Am I audible, ma'am?
Yeah, perfectly.
Yeah. Considering the risk factors in this patient, the prompt recognition and timely initiation of therapy would be more helpful for this patient. And during the delivery, a skilled maternity team involving a midwife or obstetrician would be helpful in order to prevent the PPH. But after delivery, the monitoring of the women and the uterus should be considered. A monitoring of the women with all those vital parameters of heart rate, BP, and the visual estimation of the blood loss rather than the measured blood loss. So a senior obstetrician who can guide the team members would be more helpful in this patient. And with this altered coagulopathy, a risk of vaginal hematoma will be there. And all those blood products should be made available, and multidisciplinary approach along with the hematologist and also the trained staffs and anesthesiologists should be kept ready. All those blood products should be kept ready. And also the fluid resuscitation and the monitoring of the patient along with the lab parameters should be considered. A strict vigilance of the women and monitoring is more important in this.
Yes, so very well said. And one more thing, that if you are doing a cesarean, we should, I think it's a good idea to put a drain, because you can diagnose any hemoperitoneum is any place she's, trickling, you can diagnose early and take the necessary action. And of course, we have to be very careful in such cases, if they have PPH, hypotension can precipitate encephalopathy in the acute liver failure. So we have to, try to prevent it. But of course, it is inevitable at times, as was in our case. And she did go into encephalopathy on day 2, and we had to intubate her. But as I said, luckily on day 4, she was extubated, and after 1 week, she was sent to the ward. And she was discharged after 3 weeks. So this was a success story for us. So now, next slide, please. Have we finished this case? Yeah. So Shiva, before I hand over to you for second case, I would like our expert, Dr. Bharti, to give her comments, so we can then move over to the second case. Dr. Bharti, you are muted.
Sorry. Thank you for giving me the opportunity, and I congratulate the organizers for this excellent deliberation. There are a few things which I would like to point out in the management of this case. I think the first thing is when we know the case history and the complications, she's already in AFLP. I think a proper counseling is of utmost importance because there's a high risk of mortality and morbidity in cases of AFP. So a very systematic counseling and consent, informed consent of all the complications need to be explained to these patient and the attenders. And the second thing is, if the case is in a primary care or a secondary care, I think they should, if possible, shift to a place where there is a multidisciplinary approach. And I think even before we anticipate, as we're anticipating PPH, blood and blood products should be cross-matched and kept ready. The blood bank should be informed for a massive drug transfusion necessity may be there, and inform the intensivist, hepatologist if available, and a physician, and take it up as a multidisciplinary approach and anticipate the problems even much before we land up with PPH. This is what I would like to add on to the discussion. Thank you.
Thank you. Thank you for the very good points, Dr. Bharti. So very, very well taken. So next, Dr. Shiba, can you take the next case, please?
Yes, thank you, ma'am. So quickly moving to the second case scenario. So she was a Mrs. X, 25-year-old, unbooked, para 1, live 1, A3, who was admitted through gynae emergency of Safdarjung Hospital on postnatal day 8 of a preterm vaginal delivery with complaint of pain abdomen since 2 days and bleeding per vaginum since 2 days. She gave history of soaking around 4 to 5 pads which were fully associated with passage of clots. And she had also history of 3 spontaneous abortions in her first trimester, each of which was followed by a DNC. Her last delivery was preterm delivery at 32 weeks, where she delivered a 1.6 kg baby and who went to nursery. So on examination in GRR, her general condition was fair, patient was afebrile, her vitals were stable, pallor was present, clinically she seemed to be 7 gram%. On per abdominal examination, no evidence of any organ enlargement was seen and uterus was well contracted to around 16 week size. On per speculum examination, mild bleeding was present. However, no clots were seen, and on per vaginal examination, it was a parous os with uterus corresponding to 16 week size, anteverted, mobile, and bilateral fornices were free and non-tender. So we ordered an ultrasound in emergency, and which showed this picture where a lot of vascularity was seen. She was admitted for observation in the ward. Her routine investigations were sent, which came within normal limit, except her hemoglobin, as expected, was 7.2 gram%. Ultrasound pelvis was done, which is suggestive of uterus postpartum, with a heterogeneous collection of 6 into 3.5 centimeter on the posterior wall with increased vascularity. The bilateral ovaries were normal on ultrasound with no free fluid in the pouch of Douglas. So my question to Dr. Murugulakshmi would be, what would be the differential diagnosis for this case, madam? And how would you proceed to manage this case? And if you go for DNE, should we proceed for DNE directly? And in that case, what would be the risks for this patient?
She is a case of secondary PPH. Yes, so the differential diagnosis for a case of secondary PPH are retained products of conception, sepsis, placental site trophoblastic tumor, or pseudoaneurysm of the uterine artery, or peri-AV malformation. So in order here, we have only 2 things to be left out. That is, either it can be in retained products of conception, that is an adherent placenta, a focal adherent placenta, or it can be a placental site trophoblastic tumor. Since your investigations reveal everything normal, I would rather think in case of an adherent placenta. So I would like to confirm it by doing an MRI. Excuse me, and confirm the diagnosis. Now, if the MRI turns out to be an focal adherent placenta, since the patient is a para 1 live 1 with an abortion free with a preterm labor of 1.6 kg in the NICU, sorry, I would like to proceed with conserving the uterus, giving methotrexate, sorry ma'am, and follow her with HCG, or else I may plan for an uterine artery embolization, or if she is not affordable for it, I may plan for an PPP procedure, that is removal of the placenta. Since it is a focal adherent placenta, I may remove.
Shiba, you can take over. I think madam is having, ma'am, you please have some water. You can have some water.
Yes, ma'am. You had very rightly said. So the diagnosis could be any of the three. And in this patient, so we went well uterine artery embolization to conserve the
Thank you,
uterus
ma'am.
for
I'll have.
evacuation the next day, which was done. So uterine artery embolization is a non-surgical minimal invasive technique in which is done in hemodynamically stable patients, as was in this case, where gel form or PVA particles are used to embolize the uterine artery. So my next question would be for Dr. Richa, where, ma'am, what are the indications of uterine artery embolization in cases of PPH?
Rightly said, as in this case, retained placenta or products unlikely because it looks more of a mass on the posterior wall. All the findings were normal. Patient is definitely bleeding on such that her pallor is of HB that much dropped to 7. As well as if we see the history wise, she has 3 procedures done as DNC for the previous miscarriages, as well as there was a preterm birth. So again, a very high chances for placenta, focal accreta, or that spectrum. So uterine artery embolization is a procedure where you want to conserve, it's kind of a conservative, uterine conservative surgery, or uterine when you want to minimally invasive techniques. So for first, I would suggest a course of antibiotics, and like ma'am said, maybe give methotrexate and wait rather than going into a direct DNC or a repeat DNE or any surgical management. Wait and watch and maybe reassess like with beta HCG as well as, and then only, because we are having a very high suspicion of this focal accreta spectrum. So again,
sorry to interrupt. If the patient is bleeding and has become anemic, I don't think we can wait for too long. We have to do something. No?
So if it is because her parity is only 1 now, so we would like to conserve the uterus. I would like to say that uterine artery embolization for her with the simultaneous resuscitation of her general condition would be an option for this case in this pregnancy for her, since we are just conserving the uterus. So in obstetrics, other indications of uterine artery embolization is always when we are suspecting AV malformation and other things. But like you're saying, ma'am, if a patient is otherwise hemodynamically stable, but HB is dropping, there is some ongoing bleeding going on. So we will, and looking at her parity, would like to conserve the uterus and go do the uterine artery embolization, which was rightly done for the patient.
Yes, very correctly said, Dr. Richa. So as this patient had a lot of vascularity and the retained products were already there in posterior wall on the ultrasound, and she was bleeding, we had to intervene, and considering her parity and her bad obstetric history, we went ahead for uterine artery embolization, which was available in our setup, followed by DNE the next day. So the procedure of uterine artery embolization for everyone, it is IV hydration is maintained, bladder is catheterized, antibiotic prophylactically is given, NSAIDs are given pre-procedure, arterial access is gained through femoral artery most of the times. A diagnostic angiogram is done, and super selective catheterization is done using microcatheters around under the roadmap. And embolization is done, as I've already told, with embolic particles, with PVC particles, they are gel foam particles, they are used, and this is done. And this is a picture of the angiogram of the uterine artery embolization, and which is pre-embolization, and the second one is the post-embolization to decrease the vascularity. So the advantages is the surgical incision is avoided, the general anesthesia is avoided, there is no blood loss, and a shorter recovery time in the patients. And so my next question goes to Dr. Varuna. Any complications of uterine artery embolization, and especially in this patient, what is the outcome for future fertility for this patient? Because she was quite concerned whether after uterine artery embolization would she be able to conceive or not.
Yeah, the complications I would like to add is like she'll be having, they're little prone for infection. They might have not much percentage, but in next pregnancy, they'll have preterm labor, or the chances of placenta spectrum disorders might be there. And the fertility, it's not like exactly, it's 50% decrease. They're more of cohort study where it showed around 61% of people have reduced their fertility, but they're not absolute infertility rate.
Yes, very well said, Dr. Varuna. So the complications of uterine artery embolization for all the postgraduates attending this panel are immediate, early, and late complications. Immediate are often the local complications like the groin hematoma, the arterial thrombosis, dissection, or pseudoaneurysm, which are encountered while gaining the access. And the early complications are those which occur within 30 days. And in this, most common is the post-embolization syndrome, where patient experience pain, nausea, fever, and malaise, which has to be managed conservatively as it is self-limiting, and it resolves within 10 days to around 14 days. And the late complications are the vaginal discharge or the persistent discharge plus pain in these patients. So pregnancy after uterine artery embolization is a reality, and we have a lot of studies on this. And now, initially there were case series, and now there were larger case series. And the Ontario trial, which was done from a period of over a period of 12 years, where 555 women underwent uterine artery embolization, and when they were followed prospectively, 21 out of them conceived and 18 live births were there. So women are able to achieve pregnancy after uterine artery embolization, and most of them were resulted in term delivery with appropriately grown newborn, provided close monitoring is done and of the placental status in the pregnancy. So
one thing, Shiba, I will just like to intervene, that I am just traveling all around the country, and even just now, this week I was in Bombay and then Kerala. The uterine artery embolization is really not available in our country for most of the situations. So I will like to say that in such situation, if this facility is not available, what we can do for saving lives as well as sometimes fertility, because it is really an issue that it is not available and accessible right at the time. So your comment also, Shiva and Josna and Bharti is also with us, that when it is not available, how to deal with this situation. Everybody, even Dr. Ashok Anand, everybody says this stitch is good, Ashok Anand stitch is good, collateral this stitch is good, because we are not having this facility in reality actually. So Josna, your comment and Bharti's comment also.
Dr. Sadhna, I think very true, madam, that it is not available very freely, no doubt about it. So see, in a patient who is bleeding and there is a focal accreta, so definitely it is a very big challenge. Methotrexate is out absolutely. We used to give methotrexate previously, but lot of studies are showing that methotrexate can cause more harm than good, because it can lead to infection, and it has got no role. Basically the studies show that it can cause in such cases with retained placenta, it can lead to further damage for the woman. So we don't give it anymore. We used to give it about a decade ago, but now we have absolutely stopped. So it's a big no. And the other options which we have, so basically we have to stop her bleeding. If there is no bleeding, we can keep the placenta in situ. We have to worry about two things: secondary PPH and sepsis. So we can give her good antibiotics, IV antibiotics. And if the PPH is not of major degree, if it is just small trickle, we can manage with tranexamic acid and give her conservative approach. Sometimes there may be accompanying endometritis, giving antibiotics may help. But then it is a very big risk, because if she has major PPH, so then we may have to do a hysterectomy. So definitely such cases who need further fertility, who are concerned for fertility, ma'am, I don't think we have very many options for them, and they should be referred timely, as was already highlighted by Dr. Bharti in the previous case also, that if they are worried about fertility, I think they should be referred timely to a center where this kind of facility is available.
Yes.
Because, yes.
Dr.
Bharti, you want to add anything?
As said by you rightly, uterine artery embolization is not a reality for many of us. But I think in such situations nowadays, with the improvement in the transport and the roads, we need to refer them to one of the metros or the hospital where this facility is available. Because as Dr. Jyotna said, our options are very few here, especially when they require fertility. But if it comes to a point when fertility is not in a question, control the sepsis, give her tranexamic acid, and then once her general condition improves, we can repeat the scan and see Doppler studies, and if she stops bleeding, we can observe. She continues to bleed, hysterectomy would be an option when fertility is not an issue. But otherwise, I think timely reference to a tertiary care center is what would be the best for this woman.
Yes,
Thank you. Because I just brought out, because everybody
Yes.
should have this message that if it is not available, what to do.
Yes.
And a little bit fertility issue is also with the, because even for fibroid, we don't, it is a second line option. So it is a compromised fertility, but of course the life saving and the fertility sparing thing option. So thank you very much. I just, sorry that I intervened, but I thought that
No, it was a very valid point. Very valid point.
To do a DNC for them. Do not rush in to do a DNC.
That is delayed. We can do once the blood supply is not there. So hysteroscopic, many times we can do, if it is a focal placenta accreta, we can do the hysteroscopic removal. Yes, after the resorption takes place and it is no longer taking blood from the surrounding decidua from the uterus, then we can take it to the OT.
Yes, thank you, Sadhana ma'am, and thank you, Bharti ma'am, for those valuable inputs. And now I would like to request Dr. Jyotsna ma'am for taking us to the last case scenario, the difficult, challenging one which we faced.
Thank you, Shiba. We'll have a quick, because we are, I think, already late.
Short of time.
So, yes, short of time, but it will be like a rapid fire. So P1 L1 with previous vaginal delivery 12 hours back, referred with history of traumatic PPH with, excuse me. Yeah. So P1 L1 with previous vaginal delivery 12 hours back, referred with history of traumatic PPH, cervical and vaginal lacerations were there, and patient was, referred with the PAC in situ. And on examination, her heart rate was 120, BP was 90, shock index was more than 1, and respiratory rate was 28 per minute. Pallor was present about 6 gram. Per abdomen, her uterus was 20 week size, well contracted. And when we saw her, her pack was partially soaked with blood. So in such case, Dr. Silambulchelvi, what would be I'm sorry about the pronunciation. It's a tongue twister for me. So yes, sorry about that. So could you broadly tell us about the steps of management in this case?
Thank you, madam. She is a case of traumatic PPH, and she is hemodynamically unstable. So my plan is to resuscitate her and explore her simultaneously. So I'll call for help first. Not only my team, I'll call anesthetist also, because he will keep me calm by taking care of the hemodynamic status of the patient. At the same time, he will keep the patient comfortable by giving anesthesia, because anyhow I have to explore. Without anesthesia, it is very difficult. So under IV sedation, under good light, I will explore the patient.
Good. Yes. So that is what we were looking for, that we will not straight away take out the pack in the emergency or in the labor room, but with all full preparation of blood and blood products. And
in the meantime, I will start 2 wide bore IV line.
Yeah. All those we will do. I think we are short of time. We'll just touch the important. Absolutely. All those things we have to do, and we would take her to the OT. So cervical exploration was done, and a cervical tear of 6 to 7 centimeters was noted at 6 o'clock position. And a right lateral vaginal tear was also seen, the apex of which couldn't be reached. So, So now how to manage? We have already taken out the pack. She is in good hands in the OT. Blood products are there with us. Anesthesia colleagues are there. She is under anesthesia. We have found this, finding has been there. So Dr. Jayanti, we can't...
We can suture it from wherever we are able to see that tear, we can suture. From after suturing that, we can able to reach the apex better. Then we can completely suture it. Even the lateral vaginal wall also, we can completely suture it under the good light.
Yes.
And we can make sure it's hemostatically secure.
Yes, so for cervix, perfectly okay. We can see the apex, we can do it. And as you rightly said, if we can't see, we can go from below and then
No, and
gradually
then we can reach
the
them.
fraction and go. But in this situation, when in the vaginal, the lateral vaginal, Shiva, next slide, please. Next, please. Yeah. So in this situation, we could not see the apex at all, even after trying the way you told. We were doing from below and we were giving traction, so we could not reach the apex. So here then we had no option, but laparotomy had to be done for such a case. So important, next please, Shiva. The pitfall of repair of a vaginal tear from below in such cases is that, as you said, sutures should not be placed straight away at the top, but from the bottom. But if you suture is placed cephalic to the fornix, so if the tear is higher than the fornix, this can result in the ureteral ligation. So we have to be very careful. If you can't see the apex, then don't put blind sutures there. Laparotomy, or as we were discussing, even here there is a role of embolization, but otherwise a laparotomy is needed when a vaginal laceration has extended above the fornix and appears to be expanding because of hemodynamic instability. So here we take the abdomino-perineal approach. We can put the patient in a modified lithotomy position, and simultaneously we open the abdomen, which facilitates the identification of the ureter's bladder and minimizes the damage to these structures. Next, please, Shiva. And one more thing, if we are, having heavy arterial bleeding, vaginal bleeding, we should not be putting pack, except to save the life of the patient. At times when you are transporting, you put, but ideally in arterial heavy bleeding, we should do, we have to catch the bleeders. Otherwise, this blood is diverted into the retroperitoneum. And in venous bleeding, vaginal packing is very effective and the, treatment of choice. So if there is a venous, continuous oozing, that is very well managed by the packing or by the tamponade. But for arterial heavy bleeding, which is coming in spurts, definitely this packing will not be a good idea. We will push all that blood into the artery will slip off, and we will end up with a big retroperitoneal hematoma. So this is what happened in this case. She already had a tear and she came with a tight pack. No doubt the pack was put to save her life, and we appreciate the primary center which had sent to us. But the problem was that she ended up with a big retroperitoneal hematoma. So laparotomy was done and a big broad ligament hematoma of around 6 to 7 centimeter was seen on the right side. And Dr. Shri Devi, how should we tackle this hematoma now? And what are the challenges in this kind of a picture, when you open the abdomen, and are there any alternatives also?
Yes, ma'am. If it would be a non-enlarging hematoma, it can be observed, and any bleeding points or bleeder should be identified and sutured. And if it is an enlarging hematoma, the broad ligament should be opened and the clot evacuated, and the bleeder or a bleeding site should be identified and sutured. Exteriorization of uterus would be helpful, and gentle traction of the uterus would be helpful in adequate visualization of the apex of the lateral vaginal tear.
Yes. Yeah. Thank you. Thank you so much. So Dr. Shri Devi has told us that she would like to drain the hematoma. Yes, definitely. It's a supralevator hematoma, and as we said that high tear has, the arterial arteries have slipped higher, the bleeding arteries, and they have gone into the retroperitoneum, resulting in the hematoma. So normally it arises, this picture we have put, for all of us, that the vaginal blood supply is also coming from the internal iliac. Even though there are a lot of anastomosis, they may come from other, from the external iliac, also from the femoral, we have got the supply, the external pudendal, but major is the vaginal artery and the internal pudendal. and both of them are arising from the internal iliac anterior division. So, in this case, see, this was the picture. Next, please, the broad ligament hematoma. So internal iliac artery ligation does help in definitely in any kind of a big hematoma in the vaginal artery, which has started from originating from the vagina. It will help us to control that bleeding, because we may not find individual bleeders. They have slipped up. So then, you have to control it at the source. So which Dr. Shashi showed us beautifully, and she told repeatedly that all obstetricians should learn. So it is, very, very effective method. And if you learn, it is not difficult at all. If you have practiced it, learned, of course, you need to have a training for it. We cannot, there's no shortcut, but it can save the life of a patient in such situations. So this is what we had done in this case. The anatomy is all distorted during the, hematoma when it extends. So it is not very easy, as shown in the video of Dr. Shashi, that when you do it for a atonic PPH or for a accreta, then different anatomy is there. But when there is a broad ligament hematoma, the tissue becomes very edematous, very friable, and it is more challenging to do. So only an expert should attempt it. Otherwise, the other option is that, you just put a pack, drain it, put a pack, and if she is hemodynamically stable, we have other options of going in for the embolization also. So this is what Shiba has compared the arterial ligation and the arterial embolization. Here in arterial ligation, if she's unstable, you should go in for that. And if she's stable, you can go in for the embolization. So Shiba, you can go to the last concluding slides.
Yes, ma'am. So to summarize after this panel, as we've all learned through these 2.5 hours, that PPH drill is very important, and hemostasis is the mnemonic which we highlight that hemo is the medical management and stasis is all the surgical management. And intervention radiology is the one thing which is coming up in all the tertiary care centers nowadays, and which is really helping us with the patients, especially where the obstetric histories are compromised. And then the bundle approach, we must wanted to highlight that the FIGO 2022 has endorsed that the bundle approach should be in the armamentarium of all the obstetricians in all the tertiary care hospitals, and even the stress should be laid on the primary and the secondary centers as well, where every unit should be ready for managing PPH patients. The hemorrhage card should be there, the immediate access to hemorrhage medications, response team to whom to call to, massive and emergency release transfusion protocols should be made, and unit education on protocols and unit-based drills should be performed. And also after that, there should be recognition and prevention in every patient of PPH, because early diagnosis is very important, and it goes a long way in saving the lives of these mothers, where active management of third stage of labor is also very important to prevent PPH. Now, once PPH occurs, the response is also very crucial in every hemorrhage, where a uniform, standardized, stage-based obstetric emergency management plan should be prepared with checklists. Support programs for patients, families, and staff for all significant hemorrhages should be there. And this, apart from all this, the reporting and the system learning, because every case is an experience for every one of us, and we all learn through our experiences. So every unit should establish a culture of huddles for high-risk patients and post-event debriefing to identify successes and opportunities. A multidisciplinary review of serious hemorrhage cases should be done, and outcome monitoring and process metrics in perinatal quality is also there. So a take-home message is that PPH is the leading forerunner in the near-miss audits. The responsible fearsome 4 Ts are tone, trauma, tissue, thrombin. The risk factors for PPH are known to all, but not always possible to prevent it successfully. It is a major cause of mortality and morbidity if too little is done too late. That's why the importance of golden hour is pivotal, and staff should be familiar with an agreed protocol to be implemented quickly and smoothly once PPH occurs. Every pelvic surgeon should be able to perform the stepwise devascularization and ligate the internal iliac artery. Specific approaches considered to enhance the obstetric patient safety, including checklist protocols, simulation training, and teamwork training should be there. Clinical elements should be there to ensure successful implementation of this program, teamwork, communication, facility readiness, network integration, and data monitoring and quality improvement goes a long way in preventing the morbidity and mortality associated with PPH. So the way forward is that we all should prevent PPH. And Stephen Hawking said that however difficult life may seem, there's always something you can do and succeed at. So safe maternal care and every woman counts is all our goal. And we thank you for this your patient listening and a very interactive panel to all the panelists and vital inputs from Dr. Bharti and Dr. Sadhana as well.
Yeah,
thank you so
we
much.
want to thank Dr. Sadhana again for giving us this opportunity and wish her all the best for the upcoming elections, and want to see her at the top position, because
Thank you,
she is
Jyotsna,
so,
thank you very much.
Your passion for saving the woman's life is unparalleled. Thank you.
Thank you, Jyotsna, and excellent panel. Thank you, Jyotsna and Shiva, and all the panelists give wonderful inputs, and it is always a lot of learning from every panel and every experience. Thank you
very good
much.
panel, very good panel.
Thank you, Shashi. Thank you so much.
Thank you so much, ma'am.
Thank you for the opportunity.
Thank you for the opportunity.
Thank you, Jyotsna. Thank you, Jyotsna Madam and Shiva, for the wonderful panel. It was very interactive and updated. Thank you. Thank you very much.
Thank you, Sadhana ma'am, for this opportunity, and thank you, Jyotsna ma'am, for guiding us through. And thank you to all our panelists once again.
So, Aishi, you are going to give a formal vote of thanks?
Yeah, ma'am, I just wanted to know if anybody wants to see the Cho Suchar video, then I can share my slides.
I think we can compile. A lot of marriages are there.
Okay.
So next time, or you can share on the slides, so that I think Aishi, you will give the vote of thanks.
Thank you, ma'am. Thank you, ma'am. So we have come to the end of this successful webinar in collaboration with the societies of Coimbatore, Vellore, Namakkal, and Tirunelveli. I would like to thank our chief guest, Dr. V.P. Palli sir, for his gracious presence and his words of wisdom. My heartfelt gratitude to Dr. Sheila Mane ma'am for her blessings. I would like to thank Dr. Sadhana Gupta ma'am, the key organizer, the speaker, and the intellect behind all these fantastic webinars. I would like to thank Dr. Shashilata Kabra ma'am and Dr. Nalini Mishra ma'am for such intricate yet simplified videos which are full of knowledge. Thank you, our respected chairpersons, for their valuable inputs. Thank you, Dr. Jyotsna Suri ma'am and Dr. Shiva Marwa ma'am, our moderators, for planning such intricate and brainstorming cases, and our esteemed panelists for such inputs and engaging discussion. Thank you, Bharti ma'am, for your valuable insights. And thank you, Dr. Babita Shukla ma'am, for all your hard work. Last but not the least, thank you, the IT team, for the smooth running of the program. And thank you, audience, for your patience listening. Thank you, ma'am. Good night.
Thank you. Thank you. So that we can say good night and